Assalamu alaikum. Dear colleagues, it's a pleasure for me to welcome you all to our event. This is the 8th Gulf Endocrine Review course, and it is will be going today, tomorrow, and after tomorrow over 3 days. This is number 8 for us and the Gulf Endocrine course, and we are the GATE, the Gulf Association of Endocrinology and Diabetes. You could see that we established at 2020, but actually we are here, and we started at 2012 under the umbrella of ACE Gulf chapter. And during this period, we thought it's our mission, part of our mission, to give something for our young endocrinologists and our people in training follow, and that was the course which was established, and now we are going every year, and this is number 8, and this is part of our activity to improve the outcome and the knowledge about endocrinology, and to give opportunity to our young people, endocrinologists, general physicians, diabetologists, family physicians, to have a clear idea about endocrinology. We invited actually the top leaders in the field, and you could see the names, and we'll start today with 3 big names and 3 sessions, and we will continue that over the next 3 days. So this is high caliber course, and we welcome you all to this meeting. Of course, my name is Ali Al-Ma'mari, and I am the immediate past president of the GATE, and I work at Sultan Qaboos University Hospital in Oman. And it is a pleasure for me actually to introduce Professor William Young. And Professor William Young is a professor of medicine and endocrinology at the Division of Endocrinology, Diabetes, Metabolism, and Nutrition, Tyson Family Endocrinology Clinical Professor, and Professor of Medicine at Mayo Clinic, College of Medicine and Science, Rochester, Minnesota, USA. Professor Young is one of the people who actually supported us over the years, and he presented to our meetings, and he participated previously in this course. And so it's really great pleasure to welcome him to our meetings and to start the meeting. The meeting itself will be two parts. One is the question part, question and answer, then a poll, and you have to give your answer. It will take few seconds. Then that will take around 75 minutes. Then after that, we will go to any question you want to ask about adrenal gland. You put it in the question box, and we will discuss it with the Professor William Young at the end. So we have 15 minutes also for a question and answer. Shortly after that, we will finish because there is another session that will start actually, and we want to keep things on time. So without further ado, I will request our guest, and he's talking to us from Mexico. Is that correct, Professor Young? To start his session, and I'll be with you just to support in case we need something. Professor William, please start.
Dr. Ali, thank you very much for that introduction. It's a pleasure and honor to join this course again. And I have quite a few adrenal topics to share today, but first, I do need to disclose my prior service at the American Board of Internal Medicine. I served as the chair of the ABIM Endocrinology Specialty Board 2014 to 2018, and I was a member of the ABIM Council 2014 to 2018. And I was a member of the Endocrine Exam Committee 2013 to 2019. As is true for any ABIM candidate who's taken the certification exam, I've signed a pledge of honesty in which I've agreed to keep the ABIM exam confidential. And no ABIM Endocrine Board exam questions will be disclosed in my presentation today. But the level of question and the general topic areas are going to be very similar. So why should clinicians be certified? And this is directly from ABIM. Passing your boards demonstrates you've met a rigorous standard and have the clinical judgment, skills, and attitudes essential for the delivery of excellent patient care. Most employers of physicians in the United States require ABIM certification. And then the rationale for recertifying. This has to be done every 10 years. Staying current in medical knowledge is one of the most important things you'll do throughout your career. There's a lot of evidence for why this is important, both on foundational science and actual evidence, with data associated with patient care. Knowledge increases exponentially. What we know now will be dwarfed by what we will know just 10 years from now. Unfortunately, study after study has shown that our knowledge and skills decline over time. And unfortunately, self-assessment is very poor. There's something called the Dunning-Kruger effect, which is a cognitive bias that leads us to believe we know more than we actually do. It's important because the most competent people tend to underestimate their ability, but more importantly, unskilled people tend to overestimate their abilities. That's why it's important to make sure you continue to learn and test yourself, even if you believe you're at the top of your game. To stay certified, we need to earn 100 maintenance certification points every 5 years, and then every 10 years, pass a MOC assessment, which can be the traditional 10-year exam or longitudinal knowledge assessment. So who can take the US ABIM board exam? Those who've completed ACGME certified training program. For example, to take the internal medicine board, you must have satisfactorily, as determined by your training program director, completed a 3-year training program. To take the endocrinology and metabolism boards, you must have satisfactorily, as determined by your training program director, completed the 3-year internal medicine residency, followed by at least a 2-year training program in endocrinology. This is the blueprint for the board exam. You can see that 10% of the questions are going to be focused on adrenal disorders, 10% pituitary, 12% lipids, obesity, nutrition. The biggest chunk is with diabetes and hypoglycemia, then calcium, and then thyroid. Within the adrenal, each exam will have approximately 4% of the questions directed toward glucocorticoids. So Cushing's, managed glucocorticoid therapy, adrenal insufficiency. About 2% mineralocorticoids, a little less than 2% adrenal androgens, adrenal incidentalloma, adrenal medulla, and finally adrenal cancer. It's a one-day exam in a secure testing center. It's composed of up to 240 single best answer multiple choice questions, of which approximately 40 are new questions and do not count toward the examinee's score. Now, as a test taker, you don't know what the 40 pretest questions are. These are questions that have been written by the exam committee, and they're being tried out to see how well they perform. Most questions describe patient scenarios and ask about the work done, that is, the task performed by physicians in the course of practice. So there's 4 2-hour sessions in one day. Each session has 60 questions. And that focuses on making a diagnosis, ordering, interpreting results of tests, recommending treatment or other patient care, assessing risk, determining prognosis, applying principles from epidemiologic studies, and understanding underlying pathophysiology. Clinical information presented may include various media, diagnostic imaging studies, continuous glucose monitoring, radiographic studies, patient photographs. The candidate may be asked to differentiate among imaging techniques for adrenal disease, including CT, MRI, MIBG scintigraphy, octreotide scintigraphy, FDG PET scan, dotatate PET scan, interpreting imaging phenotype to predict the histologic type of adrenal disease. In other words, does it have the imaging phenotype of a benign adrenal adenoma or that of a pheochromocytoma or adrenal cancer? Identify indications for doing CT-guided biopsies. Identify indications for adrenal vein sampling. And finally, interpret the results of adrenal vein sampling. The exam committee goals are to write clinically important, case-based questions that would discriminate between a knowledgeable candidate and a borderline candidate. We try to avoid rote memory questions, avoid all the following except type questions, and avoid true-false questions. So with that background, let's start the practice session on adrenal. Which one of the following medications is most likely to interfere with biochemical testing for pheochromocytoma? Sotalol, labetalol, prazosin, amitriptyline, or nifedipine? Okay, so the most popular answer was 53% of you picked amitriptyline, 20% prazosin, 22% labetalol, and 4% picked sotalol. So as we look at these medications, there's something unique about one of them that gives you the clue. And then there's a major knowledge piece too. The medications that increase measured levels of norepinephrine and norepinephrine most of them are psychoactive agents, tricyclic antidepressants at the top of my list. And after each drug class, I've listed the degree of elevation you can see in norepinephrine and norepinephrine, 2 to 10-fold elevation with tricyclics. Levodopa, 10 to 20-fold elevation in dopamine. So these are patients taking Sinemet for Parkinson's disease. And there's a downstream false positive in norepinephrine. Norepinephrine, 2 to 4-fold elevation. Drugs containing adrenergic receptor agonists like decongestants, typically fairly mild false positives. Amphetamines, a variable effect. B-spar and antipsychotics, 3 to 10-fold elevation above the upper limit of normal. SNRIs up to 4-fold. SSRIs, very minimal effect. Composite variable, reserpine, 3 to 10-fold increases. Withdrawal from clonidine, withdrawal from illicit drugs, depends on the stage of withdrawal. Ethanol, similar stage of withdrawal. But with current assay methodology, which for reference labs is tandem mass spec or HPLC, blood pressure meds and acetaminophen do not interfere with testing. So when we look at this question, well, sotalol is a blood pressure medicine, labetalol is a blood pressure medicine, prazosin is a blood pressure medicine, nifedipine is a blood pressure medicine. The only psychoactive agent here is amitriptyline, and that uniformly causes false positive testing. Amitriptyline is a tricyclic antidepressant up to 10-fold above the upper limit of normal. So the correct answer is D, amitriptyline. Next question. In a patient with a solitary adrenal pheochromocytoma, von Hippel-Lindau syndrome is most likely when which one of the following is also present? Pancreatic islet cell tumor, mucocutaneous neuromas, large cafe au lait spots, axillary freckling, everted eyelids. Well, this is good. See, it shows that the distractors are good. So from the exam writing perspective, you don't want 100% of candidates to get the correct answer. And you want some of the distractors to actually get some people to answer. So 28% said pancreatic islet cell tumor, 30% said mucocutaneous aromas, 26% cafe au lait spots, 14% axillary freckling, and only 2% said everted eyelids. So as we look at these responses, mucocutaneous neuromas are seen with multiple endocrine neoplasia type 2B. Large cafe au lait spots are seen with neurofibromatosis type 1. Axillary freckling, neurofibromatosis type 1, and everted eyelids, MEN 2B. So if you didn't know pancreatic islet cell tumor was part of von Hippel-Lindau syndrome, you could come to that correct answer by recognizing that these other distractors are associated with other known VO syndromes. So the correct answer is pancreatic islet cell tumor. So von Hippel-Lindau syndrome is pheochromocytoma, frequently could be bilateral, and they also can have paragangliomas, retinal angiomas, cerebellar hemangioblastoma, epididymal cystadenoma, renal and pancreatic cysts, pancreatic islet cell tumor, and renal cell carcinoma. So we screen these patients annually with MRI of the abdomen, where we're screening not only for pheochromocytoma, which we'll do biochemically, but we're doing that MRI primarily for the renal cell carcinoma risk and the pancreatic islet cell tumor risk. Okay, third question. 16-year-old girl is referred for hypertension, hypokalemia. She's asymptomatic and has regular menstrual cycles. There's a strong family history of hypertension in her mother and 2 maternal aunts. On physical exam, she appears healthy. Her blood pressure is high, 142/94. She has no excess facial hair or acne. Endoscopic exam was normal, no leg edema. Serum sodium was 145, potassium 2.9, chloride 100, bicarb 33. Aldosterone was undetectable. Plazarine is less than 0.6 nanogram per ml per hour. Treatment trials with dexamethasone and spironolactone did not correct the hypokalemia, but treatment with amiloride corrected the hypokalemia and the hypertension. What is the most likely diagnosis here? Little syndrome, surreptitious licorice root use, congenital apparent mineralocorticoid excess, surreptitious diuretic use, or 11-beta hydroxylase deficiency. And you can enter your answer now. Most popular answer was little syndrome, 54%. Then comes 11-beta hydroxylase deficiency, a form of congenital adrenal hyperplasia, then congenital apparent mineralocorticoid excess, and surreptitious licorice root use. Okay, well, I want to kind of go over how to think about the differential diagnosis of hypertension and hypokalemia. The correct answer is little syndrome, but let me show you how we get there. So patients with hypertension, hypokalemia, you measure aldosterone and renin. If renin's elevated, aldosterone's elevated, well, that's secondary hyperaldo. So that's going to be renovascular hypertension, diuretic use, renin-secreting tumor, malignant phase hypertension, or coarctation of the aorta. Whereas if renin's low and aldosterone's high, that's going to be primary aldosteronism. Now, this question I just shared with you has to do with a patient with low renin and low aldo. So the possibilities are congenital adrenal hyperplasia, exogenous mineralocorticoid, deoxycorticosterone producing tumor, Cushing syndrome, 11-beta hydroxysteroid dehydrogenase deficiency, altered aldometabolism, or Little syndrome. Key to this case was recognizing that spironolactone and dexamethasone did not help, but amiloride did. Dexamethasone would have helped if the patient had congenital adrenal hyperplasia. Dexamethasone would have helped for 11-beta hydroxysteroid dehydrogenase deficiency, and it would have helped for apparent mineralocorticoid excess. Spironolactone would have helped if it was due to a mineralocorticoid, like exogenous mineralocorticoid or a dope-producing tumor or Cushing's syndrome. So the key is amiloride did help. Spironolactone didn't help, Dex didn't help, but amiloride did. And amiloride is very specific for Little syndrome. Little syndrome is caused by mutations in the beta or gamma subunits of the amiloride-sensitive epithelial sodium channel. This results in enhanced activity of the epithelial sodium channel, increased sodium reabsorption, potassium wasting, hypertension, and hypokalemia. Clinical genetic testing is available. You can go to the genetic testing registry to find the labs that offer this genetic testing. And as would be predicted, amiloride and triamterene are very effective agents to treat the hypertension and hypokalemia in these patients. Okay, let's go to question number 4. 47-year-old man with hypertension and 10 years duration, previously controlled with 2 drugs. It accelerated 7 months ago, and he's developed spontaneous hypokalemia. Blood pressure and hypokalemia are controlled with 6 antihypertensive meds: calcium channel blocker, a beta blocker, central alpha-2 agonist, an ARB, a direct vasodilator, and hydrochlorothiazide. He's also taking 60 milliequivalents of potassium a day. If there was a surgical option to decrease his dependence on medications, he would like to pursue it. On physical exam, his blood pressure is controlled, but that's to get there, he's on 6 drugs. Heart and lung exam's normal, no abdominal bruit, and peripheral pulses are normal. The plasma aldosterone is 13 nanogram per dl, which is 361 picomole per liter. Plasma reactivity is low. 24-hour urine aldosterone excretion on a high sodium diet is 19 micrograms. The high sodium diet's confirmed with the 24-hour urine sodium of 203 milliequivalents. If someone's on a high sodium diet, which you've confirmed with the urine sodium, normal urinary aldo would be less than 12 micrograms. In this case, the patient's 19 micrograms. Here's the CT scan. The radiologist read this that showed slightly prominent adrenal glands, but no worrisome findings. The best next step in management is A, laparoscopic right adrenalectomy, B, spironolactone, C, adrenal vein sampling, D, captopril stimulation test, or E, posture stimulation test. So you can enter your answer now. So 73% of you picked C, adrenal vein sampling, 11% picked the captopril stim test. So as we look at these options, what we've learned just by reading through the stem of this question is that the case detection test is positive with a blood aldo at 13 and a suppressed renin, and the confirmatory test is positive. The urinary aldo is inappropriately high on a high sodium diet. So the captopril stim test is another confirmatory test, but we've already confirmed the patient has primary aldo. The posture stimulation test can help predict if a patient has unilateral adrenal disease or bilateral adrenal disease, but it doesn't tell you if it's in the right adrenal or left adrenal. Spironolactone, sure, you could treat the patient medically, but remember, he he's keen to consider surgery if it could help him. And laparoscopic right adrenalectomy, the right adrenal is a little thicker than the left, as I looked at that CT, but that you can't use that to direct surgery because you don't know if that thickening is due to an aldosterone produced adenoma or not. So the majority of you got this correct, and that adrenal vein sampling is the best next step here. So this is the algorithm for primary aldo. The Endocrine Society is currently writing the next set of guidelines, and we're still in the writing phase, but I believe we're going to say that all patients with hypertension should be considered for testing for primary aldosteronism. It's done by measuring aldosterone and renin. Renin can be measured as plasma renin activity or plasma renin concentration. If the aldosterone is generous, above 10 nanogram per DL or 277 picomoles per liter, and the plasma renin activity is inappropriately low, that's a positive case detection test, and we need to confirm PA with either a 24-hour urine aldo on a high sodium diet or a 4-hour saline infusion test, or you could do the capillary stimulation test that you saw on the previous slide. If the 24-hour urine aldosterone is inappropriate for the high salt diet, greater than 12 micrograms, or on the saline infusion test, if the aldo is greater than 5 to 10 nanogram per DL, that proves the patient has primary aldo. And then we need to do subtype testing. Start with adrenal CT to make sure they don't have adrenal cancer, and then adrenal vein sampling if we excluded adrenal cancer, and if the patient wants to pursue the surgical option. The CT scan shows adrenal cancer, or if you find unilateral aldosterone excess on adrenal vein sampling, unilateral adrenalectomy is the best treatment. Whereas if it's bilateral on adrenal vein sampling, treat with a mineralocorticoid receptor antagonist like spironolactone. So this patient did have adrenal vein sampling. The first thing I look at are what the cortisol values. You want to see the cortisol levels from the adrenal veins, at least 5 times higher than background. So background is IVC, the cortisol's 28 microgram per DL. And you want the left and right adrenal veins to be at least 5 times higher. And usually it's nowhere near 5 times higher. It's 10 times higher, 20 times higher. That just proves that the radiologist was successfully in both adrenal veins. Then what's the aldosterone? And it's pretty obvious where all the aldosterone's coming from in this patient. It's 11,000 from the right adrenal vein versus 303 from the left. But I'm just going to take you through the arrhythmia, and 0.33 on the left. We divide the high side on the right, 7.92, by the low side, 0.33, and we get a gradient of 24 to 1. Anything more than 4 to 1 is consistent with unilateral adrenal disease. The other thing that's good to see is contralateral suppression, where you're dividing the low adrenal aldosterone to cortisol ratio of 0.33 by that gradient in the IVC, telling you that this left adrenal is relatively suppressed. Anything less than 1 is contralateral suppression. So it turned out that indeed this patient did have unilateral disease. It was in the right adrenal gland. And here's the aldosterone produced adenoma. It actually is quite small, it's 7 millimeters. Plasma aldosterone was undetectable post-op, hypokalemia resolved, and 3 months later, hypertension was controlled on 2 antihypertensive drugs. Okay, question 5. An asymptomatic 18-year-old young man seeks advice on a genetic test result. His mother had a paraganglioma removed, and a germline genetic testing was done, and it was positive for a pathogenic variant in SDHB. Your patient also tested positive for the same pathogenic variant in SDHB. Physical exams are remarkable. Biochemical testing for a catecholamine-secreting tumor is normal. You advise the patient that although he has inherited the mutation, he's at 0 risk to develop a paraganglioma because of maternal imprinting, or B, he has a 90% chance of developing a paraganglioma. Or C, he's at risk for developing a metastatic paraganglioma. Or D, he's at high risk for developing papillary thyroid cancer. Or E, he's at high risk for developing a pancreatic neuroendocrine tumor. Enter your answer now. Okay, yeah, this is a tough question. 38% said high risk C, developing metastatic paraganglioma, and 33% said high risk of pancreatic neuroendocrine tumor. So I'll just walk you through how to think about this. The succinate dehydrogenase mutations, the penetrance rate and the probability of developing a paraganglioma who carries a mutation depends on the specific gene that has the pathogenic variant. So the penetrance for SDHD is 50 to 60%. So 50 to 60% of carriers for this mutation will, in their lifetime, develop paraganglioma. The penetrance for SDHB is lower, 25 to 30%. For SDHA, it's very low, 1 to 5%. The way to remember the key part about SDHB is pathogenic variants are highly associated with metastatic disease. So SDHB, B for bad. And SDHG pathogenic variants are associated with maternal imprinting, where the penetrance is dependent on the parent. If the mutation is inherited from the mother, the penetrance is 0. Whereas if the mutation is inherited from the father, the penetrance is 50%. So way to remember this is SDHD, D for dad. The non-paraganglioma neoplasms associated with SDH mutations are not pancreatic. They're renal cell carcinoma and gastrointestinal stromal tumors, just tumors. So when we think back to this question, he's at 0 risk to develop because of maternal imprinting. Well, this is SDHB. Maternal imprinting happens with SDHD. 90% chance developing a paraganglioma. Well, again, the penetrance for SDHB is 25 to 30%, so that's not correct. High risk developing papillary thyroid cancer, that is not one of the high-risk cancers associated with the SDH mutations. Same is true for pancreatic neuroendocrine tumor. So the correct answer is C. He's at risk to develop metastatic paraganglioma. 6th question. 63-year-old man is referred for evaluation of adrenal mass. He had surgery for esophageal carcinoma 5 years ago. Current CT shows a lipid poor, 32 Hounsfield units, and vascular 3.6 centimeter adrenal mass. He has hypertension treated with a beta blocker, and he has no signs referable to adrenal dysfunction. BMI is 24, blood pressure 132 over 87, heart rate 88. You advise the patient that the best next step in management of his adrenal mass is CT-guided adrenal biopsy, 1 milligram overnight dexamethasone suppression test, 18F fluorodeoxyglucose PET-CT, plasma fractionated metanephrines, or laparoscopic left adrenalectomy. Okay, 61% of you got this correct. Plasma fractionated metanephrines. The best distractor was B, 1 milligram overnight dex suppression test. And, B is not necessarily wrong, since most patients, nearly all patients with adrenal incidentalomas should be screened for that subclinical Cushing's with the overnight dex suppression. But this patient had esophageal cancer in the past. Now we have a very suspicious adrenal mass. It's lipid poor, it's vascular. It could be metastatic disease, it could be a pheochromocytoma, it could be a small adrenal cancer. So you might need a CT-guided biopsy and view his history of esophageal cancer, but you should never stick a needle in an adrenal mass unless you've excluded pheochromocytoma first. So that's the gist of this question. So D, plasma fractionated metanephrines, is indeed the correct answer to this question. And he may need laparoscopic left adrenalectomy E, but again, you need to know if it's a FEO first. Okay, question number 7. 17-year-old girl presents with primary amenorrhea and lack of pubertal development. Serum estradiol is low and gonadotropins are high. She's had no development of secondary sexual characteristics. She has newly recognized hypertension. Renal function is normal. Serum potassium is low. 11-deoxycorticosterone and progesterone are elevated, and DHA sulfate is low. This presentation is most consistent with 3-beta-hydroxysteroid dehydrogenase deficiency, side chain cleavage enzyme deficiency, 17-alpha-hydroxylase deficiency, 21-hydroxylase deficiency, or 11-beta-hydroxylase deficiency. And you can enter your answer now. So when I was a fellow, I hated questions like this, just because it meant, boy, I had to memorize, the steroid pathogenic synthetic pathway and the different enzymes. Now, no one picked B, and that's good, because that would be very high up in the synthetic pathway and would not give you this clinical presentation. But with the hypertension, hypokalemia, there are only 2 forms of congenital hyperplasia that give you hypertension, hypokalemia, and she has one of those 2 forms. And they cause hypertension, hypokalemia by increasing levels of DOAC. So it's either an 11 block, which is here, so you can't make cortisol, but you get a buildup of DOAC, which is a weak mineralocorticoid. In that setting, metabolites are pushed over to the right of this pathway, so you get excess androgens, you get premature puberty and andronized females, but that's not what we have here, is it? She's had no pubertal development, so she doesn't have an 11 block. So it must be the other one that causes hypertension, hypokalemia, and that's a 17 alpha block, which is over here. 17 alpha block, you cannot make estrogens, you can't make androgens, you can't make cortisol. And so everything goes down this pathway and you get a buildup of DOAC, hypertension, hypokalemia. So with this, lack of pubertal development, and that fits with the patient that we're discussing here. So she has a 17 block. So for those trainees that are going to be taking boards, it's just a matter of memorizing this pathway, recognizing there's only 2 forms of congenital hyperplasia that can cause hypertension, hypokalemia, the 17 block and the 11 block, and then the clinical difference between those 2. Question 8, 22-year-old man presents with spells. He's been evaluated at another medical center without success and seeks your opinion. He's been troubled by spells of palpitations, sweating, tremor, and headaches. The duration of the spell is 10 to 20 minutes. They occur 7 times a week. There are no triggers or alleviating factors. Blood pressure is increased with the spell, but normal between spells. Most of the spells wake him from sleep. Plasma norepinephrine is increased at 1.3 nanomole per liter, upper normal 0.9. Epinephrine is normal. A catecholamium secreting neoplasm was not found with a CT of the abdomen and pelvis. MIBG scintigraphy showed left adrenal gland to be more prominent than the right. Adrenal vein sampling was done. And here are the results. You can see the cortisol levels from the adrenal veins and the inferior vena cava. And you can see the epinephrine levels from the adrenal veins and inferior vena cava. Based on adrenal vein sampling, laparoscopic left adrenalectomy was performed, and the pathology report indicated adrenal medullary hyperplasia. Spells persist, and plasma norepinephrine level is unchanged following surgery. He's taking no medications. The best next step in management of this patient is which of the following? test for RET proto-oncogene, measure serum calcitonin, arrange for psychiatry consultation, order a gallium-68 dotatate PET-CT, or perform laparoscopic right adrenalectomy. So 50% said dotatate PET, 16% psych eval, 18% RET proto-oncogene. Okay, well, keys to understanding this case, and I'll emphasize this on the next slide. First, the degree of elevation is really minimal in plasma norepinephrine, but we have a patient with dramatic symptoms. So there's a disconnect there. Something else that is a tip-off. His spells wake him from sleep. Pheochromocytomas don't wake people from sleep. There's a different type of spell that will wake our patients from sleep. And looking at the adrenal vein sampling study, you can see, remember, you want to see the cortisol at least 5 times high from the adrenal vein compared to the IVC. So it actually didn't get in the right adrenal vein. If you sample adrenal glands, you will get high levels of epinephrine. Adrenal vein sampling should never be done to localize a pheochromocytoma. Frequently, a pathologist will say adrenomedullary hyperplasia when a normal adrenal is taken out, because they think they have to say something important about the adrenal medulla. So those are some of the tip-offs. Oh, and finally, the MIBG scan. You can always see the left adrenal easier than the right adrenal in normal people, people without pheochromocytoma. So pearls here. In patients with spells, if a pheo is the cause, the lab value should be off the charts, more than 5-fold elevated. Remember, this patient's value was minimally elevated. The average size of a symptomatic pheo is 4.5 centimeters. They are not hard to find. Remember, this patient had negative imaging. You cannot have a symptomatic pheo and an anatomically normal gland on CT scan, which he did. Never take out an anatomically normal adrenal to treat pheochromocytoma. Can't be the cause of the problem. And there's an asymmetry in uptake in MIBG in normal individuals. Inexperienced radiologists may attribute the asymmetry to a pheo. Never do adrenal vein sampling to localize a pheo. Nocturnal spells are panic disorder until proven otherwise. So the correct answer here is arrange for psychiatry consultation. This patient has panic disorder. Question 9, you're asked to see a patient for hypertension, hypokalemia. He has borderline blood pressure control while treated with 6 antihypertensive meds. Which one of the following would be the most problematic when testing for primary LDA? A, lisinopril, B, trimethoprim, C, spironolactone, D, furosemide, or E, atenolol. 76% of you got this one correct, spironolactone. So most blood pressure meds do not affect case detection testing for primary aldosteronism. The medication class that is potentially most problematic are the mineralocorticoid receptor antagonists. That includes spironolactone and eplerenone. These drugs do not directly interfere with the measurement of renin or aldosterone, but they do block the mineralocorticoid receptor, and if the dose is high enough in a patient with primary aldo, the effect of aldo is blocked. The patient loses sodium and water at the kidney, becomes volume depleted, and renin levels rise. If renin is high in a patient on an MRA, the MRA should be stopped for 6 weeks and then rechecked. Now, here's a pearl, though. Most patients with primary aldo who are treated with MRAs are on subtherapeutic dosages. So personally, I do recommend to proceed with case detection testing in a patient taking spironolactone or eplerenone. And if renin is suppressed, then the MRA is not an issue, and you can proceed with confirmatory testing and adrenal vein sampling. So the correct answer here, the majority of you got it correct, spironolactone. We don't worry about lisinopril, trimethoprim, furosemide, or atenolol, because you're doing paired hormone measurements for aldosterone and renin. Question 10. 66-year-old woman presented a local physician with poorly controlled hypertension of 10 years. Positive family history of hypertension in 4 first-degree relatives. No tobacco or alcohol. Taking amlodipine 10 milligrams a day. Blood pressure is not well controlled on amlodipine. The patient's overweight with a BMI of 31. Sodium's normal, creatinine's normal. Aldosterone is 20. Plasma reactivity less than 0.6. Best next step in our evaluation would be to perform a saline suppression test, obtain a diuretic screen, order magnetic resonance angiogram of the renal arteries, order CT of the adrenal glands with 2 millimeter contiguous cuts, or D, perform adrenal vein sampling for aldosterone. 50% of you got this one correct. The correct answer is A, perform a saline suppression test. Those of you pick D, CT scan adrenal glands, it wouldn't be what I would do, and it wouldn't be the correct board answer. I mean, it's highly likely this patient has primary aldo, but patient does not have hypokalemia. We have a positive case detection test with an aldo of 20 and a reading less than 1. But we really haven't proven primary aldo. Does the patient have primary aldo? Most likely, but most of us would do a confirmatory test as the next step. So if we come back to that algorithm I showed you earlier, where we're at right here is the aldo is high, the renin's low. Next step is confirmatory testing. The case detection intensity, the sensitivity specificity is about 75%. So most of us, before proceeding to subtype testing, which would be CT or adrenal vein sampling, we would do confirmatory testing. And in the last endocrine society guidelines, we did provide this exception. If the patient has spontaneous hypokalemia, a blood aldo greater than 20 nanogram per dl, and a suppressed renin, formal confirmatory testing is not needed because there's nothing else it could be. But the patient I'm presenting here today, though, is normal chelemic. So that's why it's a bit different. And the correct answer would be a saline suppression test. Case 11, 55-year-old woman presents with incidentally discovered adrenal mass. She has hypertension and no signs or symptoms of adrenal gland dysfunction. Her only medications are calcium channel blocker for hypertension and bisphosphonate for osteoporosis. CT detects a 2.8 centimeter right adrenal nodule with unenhanced CT attenuation of -5 ounce per units. What's the best test to perform to determine if she has subclinical Cushing syndrome? 24-hour urine cortisol excretion, overnight DEX suppression test, 8 a.m. ACTH, midnight salivary cortisol, or 8 a.m. and 4 p.m. serum cortisol concentrations. Wow, 84% of you got this correct. Overnight DEX suppression is the best single test. 24-hour urine cortisol and midnight salivary cortisol are not very good tests to screen for this subclinical cortisol secretory autonomy. I'm going to just go through these slides. And what I've done with these couple slides is explain how subclinical Cushing's is different than clinical Cushing's and why tests that are not good for subclinical Cushing's, 24-hour urine cortisol and 11 p.m. salivary cortisol. But the best tests are measuring DHA, sulfate, and ACTH, and the 1 milligram overnight DEX suppression test. So the correct answer is what most of you got. Overnight DEX suppression is the best next step for this patient. Case 12, 34-year-old woman presents with Cushing syndrome. Signs and symptoms include hypertension, osteoporosis, easy bruising, proximal muscle weakness, supraclavicular fat pads, thick red stria over the abdomen, poor wound healing. Lab tests show elevated serum cortisol that lacked iron no variation, undetectable serum ACTH and DHA sulfate, increased 24-hour urine cortisol, upper limit of normal would be 45 micrograms. This is 393 micrograms, so close to a 10-fold increase. Adrenal CT shows a lipid-rich, -8 ounce per unit, 3 centimeter right adrenal mass, and an atrophic left adrenal gland. What's the best next step in evaluation and management of this patient? Midnight salivary cortisol, adrenal vein sampling, 2-day low-dose DEX suppression test, laparoscopic right adrenalectomy, or 24-hour urine for catecholamines and metanephrines. And 53% of you picked the correct answer, laparoscopic right adrenalectomy. 21% said 24-hour urine for metanephrines and catecholamines. And, that's never a wrong thing to do, although, as most of you know, all pheochromocytomas are lipid poor, and they're going to be 10 Hounsfield units or greater. Typical would be plus 30 Hounsfield units. So the chance this is a pheo is basically zero. So that's why the correct answer would be, we have everything we need here. We know it's due to the right adrenal mass, and the correct thing to do is to proceed to laparoscopic right adrenalectomy. 13, you're asked to see a 24-hour urine with abnormal overnight DEX suppression test. Cortisol is 8.8. Normal would be less than 1.8 microgram per DL. The test was performed because of recent weight gain. Most of her weight gain is centrally distributed. She has hypertension. Her only meds are amlodipine and phenytoin. She's taken the phenytoin since the seizure disorder was diagnosed in childhood. BMI is 33.2. Blood pressure is elevated. Normal appearing face, no acne or hirsutism. Excess body weight is distributed in the lower abdomen and upper thighs. Red striae are absent. Proximal muscle strength is normal. Which of the following is the best next management step? Pituitary-directed head MRI scan, late-night salivary cortisol measurement, 8 milligram overnight DEX suppression test, inferior pituitary sinus sampling, or measured cortisol binding globulin. And 50% of you got this correct. The correct answer is late-night salivary cortisol B. We need an alternate case detection test here. And measuring cortisol binding globulin won't provide you with the answer you need, and doing an 8 milligram overnight DEX won't provide you with the answer you need. The problem is this patient's taking phenytoin, which basically hypermetabolizes the dexamethasone. So when you're doing overnight DEX, you can be problematic. Women taking oral estrogen because it increases cortisol binding globulin. A patient they may forget to take the dexamethasone, or they could be on a drug that metabolizes DEX, like the phenytoin this patient's on. And if the offending agent, like the phenytoin, cannot be discontinued, we simply need an alternate case detection test, like midnight salivary cortisol or 24-hour urine-free cortisol. So the options here, the only other good case detection test listed would be late-night salivary cortisol. 14, 50-year-old woman referred for evaluation of Cushing's syndrome. She developed signs and symptoms of hypercortisolism in the past year. Symptoms have included marked proximal muscle weakness, 12-kilo weight gain, purple red striae over her lower abdomen, scalp hair loss, new onset hypertension. She's on a beta blocker and a calcium channel blocker. She's overweight, blood pressure is not well controlled. She has a plethoric face, full and round, marked central obesity. She has thick red striae over her lower abdomen, axillary areas. She has supraclavicular and dorsocervical fat pads, and she has proximal muscle weakness. 24-hour cortisol is markedly elevated, 833. ACTH is 73. MRI shows a normal appearing pituitary gland. You arrange for inferior pituitary sinus sampling. Here are the data. This is baseline, and this is time relative to CRH administration, or also could be DDAVP administration. And here are the ACTH values on the right inferior pituitary sinus, left, and peripheral vein. Which of the following is the best next step in management? Octreotide scintigraphy, high-dose DEX suppression test, chest CT scan, bilateral adrenalectomy, transfemoral surgery. 54% of you got this correct. E, transfemoral surgery. Patient clearly has Cushing's syndrome, and the IPSS, at Baseline, there's more than a 2-to-1 gradient, right infravertebral percentage peripheral vein. And after administration of CRH or DDAVP, there's more than a 3-to-1 gradient. So it's diagnostic of pituitary-dependent Cushing's syndrome. So there's no question here that the correct answer is transfemoral surgery. You're asked to see a 51-year-old woman with severe osteoporosis. She has bilateral adrenal masses shown here. She's hypertensive and has signs and symptoms consistent with mild to moderate Cushing's syndrome. 1 milligram overnight dex, 20 microgram per DL, 24-hour urine cortisol, 230 micrograms, upper normal 45, and DHA sulfate is low. The serum ACTH concentration and the best treatment would be which one of the following? The ACTH is 120, and the patient should have transfemoral surgery. ACTH is 240, the patient should have resection of a bronchocarcinoid tumor. ACTH is less than 10, right adrenalectomy. ACTH less than 10, left adrenalectomy. ACTH less than 10, bilateral adrenalectomy. So since we're missing option E, I'm going to stop that because the correct answer is actually option E. This patient has bilateral macronodular adrenal hyperplasia. If the patient had subclinical Cushing's, you could debulk them by taking out the larger adrenal, and that would be the left adrenalectomy. But this patient has clinical Cushing's. If you take out one adrenal, the patient is still going to have clinical Cushing's. This patient needs bilateral adrenalectomy, so the correct answer is E. 16. 52-year-old man is incidentally discovered adrenal mass, no signs or symptoms of adrenal hormone excess or deficiency, no abdominal symptoms. The adrenal CT is shown here. Axial view on the left, frontal view on the right. Based on your view of CT scan, you advise the patient that the adrenal mass is likely a benign lesion. Even with curative resection, its 5-year survival would be approximately 30%. He will need alpha adrenergic blockade pre-op. Hypercortisolism is highly likely, or he has a germline pathogenic variant in a gene responsible for this adrenal mass. So 48% of you got this correct. The adrenal mass is likely a benign lesion despite its large size. So this comes back to understanding a little bit about imaging phenotype, this question and the previous question. You can see this is a fatty lesion. See how dark it is? It's same as retroperitoneal fat. This can only be one thing. That's an adrenal myelopoma, and those are benign. B would be if it was adrenal cancer. C would be if it was a pheochromocytoma. D would be if it was probably adrenal cancer, and E if it was a pheochromocytoma. So the correct answer here is it's likely a benign lesion. So this is macroscopic fat that you see with adrenal myelopathomas, whereas adrenal cancers will look like that, vascular inhomogeneous areas. Benign adenomas are typically lipid-rich, smaller, oval, and pheochromocytomas are vascular tumors. Many times as they enlarge, they get cystic components. 17, a 28-year-old woman living in the US presented with hyperpigmentation, fatigue, and weight loss. Primary adrenal insufficiency was well documented, low cortisol, hyperkalemia, markedly increased ACTH. Symptoms responded to replacement doses of hydrocortisone, fludrocortisone. Meds include hydrocortisone, fludrocortisone, and levothyroxine. The test that has the highest probability of determining the cause of her primary adrenal failure is chest radiograph, tuberculin skin testing, blood test for 21-hydroxylase antibodies, blood test for antiphospholipid antibodies, or CT-guided adrenal biopsy. Oh, great. 83% of you got this correct. Answer C, blood test for 21-hydroxylase antibodies. It's important that the patient's in the US are not an area with endemic TB, and the patient's also on levothyroxine. That's a tip-off that she has polyendocrine failure syndrome. So C is the correct answer. 18, 23-year-old woman with Addison's disease of 3 years duration, initially had hyperpigmentation, fatigue, weight loss. Biochemical documentation included markedly increased ACTH, low cortisol, and positive 21-hydroxylase antibodies. She responded very well to glucocorticoid, hydrocortisone 15 in the morning, 10 in the afternoon, and mineralocorticoid, fludrocortisone 0.1 milligram daily replacement. However, she's been fatigued for the past 3 months. Blood TSH level is normal. Patient wonders if she should increase her dose of hydrocortisone. Which of the following parameters should be used to guide glucocorticoid dosing in this patient? ADM serum ACTH concentration, 24-hour urine-free cortisol excretion, salivary cortisol day curve, signs and symptoms of glucocorticoid excess or deficiency, blood lymphocyte count. 79% got this correct. The correct answer is D, signs and symptoms of glucocorticoid excess or deficiency. We don't have a biochemical test to tell us the correct dose. So it's not like thyroid hormone replacement. So it's basically a clinical decision. So D is the correct answer. 19, you're asked to see a 24-year-old woman just informed she was pregnant. She's in her 6th week of gestation. She has known congenital adrenal hyperplasia due to steroid 21-hydroxylase deficiency, which was diagnosed shortly after her birth. Her only medication is hydrocortisone. This is her first pregnancy, and she's concerned that her baby may have congenital adrenal hyperplasia. The best next step in this patient is obtain fetal DNA at chorionic villus sampling and perform targeted CYP21A2 mutation analysis. Stop hydrocortisone, initiate treatment with dexamethasone. Perform molecular genetic testing for CYP21A2 mutations in her husband. Measures serum 17-hydroxyprogesterone concentration, or perform amniocentesis to determine fetal sex. Yeah, so a lot of split decision here, but 41% of you got this correct. The correct answer is C, test the husband. And there's a couple of reasons for that. Chorionic villus sampling can be done at weeks 10 to 13. She's only at week 6 gestation. Amniocentesis can be done at 15 to 20 weeks. But since this is a recessive mutation, if the husband does not have a recessive gene for CYP21A2 mutation, the baby cannot have congenital adrenal hyperplasia. So that's why C is the best and simplest answer to this situation. 21-year-old woman seeks your advice after graduating from her pediatric endocrinologist practice. She was diagnosed at birth with congenital adrenal hyperplasia due to 21-hydroxylase deficiency. Current treatment includes Dex 0.5 at bedtime, Fludro 0.1 every morning. She feels well and would like you to follow with you annually. Sodium potassium are normal. Serum androstenedione is 20, so it's below the lower limit of normal. DHA sulfate is 25, so that's below the lower limit of normal. The best next step is add DHEA 50 milligrams daily to her current treatment program. Measure serum ACTH. Measure serum total and bioavailable testosterone. Decrease her glucocorticoid dosage, or measure serum 17-hydroxyprogesterone concentration. So 41% of you got this correct. And the correct answer is decrease her glucocorticoid dosage, because you can see that she has suppressed levels, suggesting she's on excess. Your target in patients with CAH is mid-normal androstenedione, mid-normal DHA sulfate, not suppressed. If they're suppressed, the patient's on excess glucocorticoid. Second to last question. 32-year-old woman presents with new onset hypertension, facial rounding, plethora, 20-pound weight gain, new onset marked hirsutism over the past 4 months. Primary care MD obtained some initial lab tests. DHA sulfate is more than 10-fold elevated at 2,833. Which of the following diagnoses is most likely cause of hirsutism and weight gain in this patient? 3-beta-hydroxysteroid dehydrogenase deficiency, pituitary-dependent Cushing syndrome, adrenocortical carcinoma, primary pigment and nodular adrenal disease, or Cushing's due to an adrenal adenoma. So the patient presents with clinical Cushing syndrome and massively elevated DHA sulfate. this can only be one thing, and 82% of you got this correct. Adrenocortical carcinoma is the correct answer. Last question. 72-year-old woman is referred for possible FEO presenting with episodes of tachycardia, sweating, and near syncope. Lab studies are shown here. Plasma metanephrine 4.2, upper normal 0.5. Normetadephrine 1.5, upper normal 0.9. Urine metanephrine 2,800, normal less than 400. Urine normet 1,120, normal less than 900. What is the preferred imaging study for evaluating this patient? Contrast enhanced CT of the abdomen, MIBG scan, FDG PET scan, gallium dotatate PET CT, or full body MRI. And 61% of you got this one correct. The correct answer is A, a CT scan. There's no reason to do a full body image here because you actually know where the tumor is. This is the only instance where the biochemical phenotype points an arrow at the adrenal glands. To go from norepinephrine to metanephrine or norepinephrine to epinephrine, you need high levels of cortisol, and that can only happen in the adrenal glands. And therefore, the correct answer here is A. We don't need a full body image. We just need to know if it's the right or left adrenal, or maybe both, if the patient has a genetic cause. And with that, I will conclude. I'll be pleased to answer any questions that you may have.
Thank you very much, bro. It was very, very interesting, very difficult question, actually, not easy. And I think most of our, actually, they answered them correct. That's good. So we'll go through the questions, and we have still time, alhamdulillah. I'll just read the question for you, Professor Young. Thank you, Professor Young. I have 17 years old, male, hypertension and 5 medication. April 76. CT adrenal normal. Saline infusion test showed both tests ringing 277 micromole positive. What you are recommend for the next step to reach specific cause for BA? One family member died at the age of 36 with CVA.
Yeah. So this patient is young, has stiff hypertension, positive case detection test for primary aldosteronism. If confirmatory testing hasn't been done, I would do that. With a CVA at a young age in the family, this could be a family with glucocorticoid or immutable aldosteronism, and frequently their adrenal CT scan will be normal. Typically, in a case like this, once I confirm primary aldo, I would do adrenal vein sampling. And if it turns out it is due to a familial disorder, adrenal vein sampling will show fairly equal aldosterone secretion bilaterally.
Okay, thank you. In primary hyperaldo, when can we skip the confirmatory testing? Should we skip it? Without doing it?
Yeah. So what we said in the last guideline was if the blood aldo is greater than 20 nanogram per DL in a patient with a plasma activity less than 1, and if they have hypokalemia, you don't need confirmatory testing because it can be nothing else. I'm not sure what the new guideline is going to say about that particular question. And we actually may not address it. But in the end, it has to be common sense, right? We say greater than 20. Well, if it's 19 and the patient has spontaneous hypokalemia, what else could it be? It's primary aldo. So a lot of this comes down to clinical experience and common sense.
Thank you. Another question, in pheochromocytoma, when do we need to do functional study, or do we just do CT scan for localization? So functional study or also or do CT scan, and also we have our colleague Dr. Ahmed Hassan maybe interfere later on, but you give me your answer.
So 85% of catecholamine secreting tumors are in the adrenal glands. 95% are between the diaphragm and the pubis. So the money, where's the money? The money's in the abdomen. And so the very first test should be CT abdomen pelvis. And that's where you're going to find these tumors.
Okay. Dr. Ahmed Hassoun with us? Can he?
Can you hear
does
me?
he have any other answer, please?
Can you hear
Dr.
me?
Ahmed Hassoun. Yeah, you go ahead, please.
First of all, thank you very much, and good to see you, Bill. It's always nice to see you and to share your experience with us. Just quick question. Always, maybe I have asked not directly this question, but you mentioned it in one of your cases about people who are already on aldosterone, spironolactone, and you mentioned that you could still test them. I have asked this question before, not to you, to other people. What is the effect of having spironolactone on the level of aldosterone? Because we know it's a blocking the receptor, right? So what does this affect the level, and how we can interpret this?
Yeah, Ahmed, thank you for that question. Now, if you or I took spironolactone, because we're blocking the receptor, our renin levels would go up and our adrenals would make even more aldosterone. But if a patient has primary aldosteronism, you give them spironolactone. Aldosterone levels won't change until the dose is high enough that it's blocking the effect of their already excess aldosterone at the mineralocorticoid receptor, so that aldo doesn't work. And if their renin goes up, then their aldosterone levels will go up. So the only reason aldo goes up is if we effectively block the receptor and renin rises. And the key in patients with primary aldo is they need a big dose of spironolactone to fully block the receptor. And most patients are not on a therapeutic dose of spironolactone.
So you mean, Bill, if I may, Mr. Chairman, this means the renin will be elevated in this case?
Yes. That's the only reason aldo goes up, is because renin goes up.
So then how you will calculate your suspicion here about the ratio?
So if a patient is on spironolactone and I decide I'm going to screen him for primary aldo, and let's say the plasma reactivity is 4 and the blood aldo is 40 nanogram per DL, I'm going to say, shucks, the renin's high, time out, stop spironolactone, wait 6 weeks and retest. I don't calculate anything when a patient's on spironolactone if renin is elevated.
Any cut point for the renin?
Any what?
Any cut
Cut
point?
point. Level.
So, yeah, so plasma reactivity, above 1 or above 1.5 would be too high.
Okay, great. Thanks, Bill. Thanks always.
Thank you. Thank you, Dr. Ahmed Hassoun. Thank you for participation. Remaining 2 questions. When can we skip the AFS in patient with the primary hyper and jump to surgery? Halas, we go ahead and cut.
So we can skip AVS in a couple circumstances. One is if it's a young patient, less than 35 years of age, with severe PA, meaning plasma aldo greater than 30, renin suppressed, spontaneous hypokalemia, and the CT shows clear-cut unilateral adrenal nodule, the other adrenal totally normal. Because the development of adrenal nodularity is dependent on age, people less than 35, we can trust the CT scan. That's one group. The other group, patients primary aldo, but they also have subclinical Cushing's. They have a 1.5 centimeter adrenal mass. We should screen all of them for subclinical cortisol autonomy, and that requires a big factory. And I don't have a good medication to treat subclinical Cushing's. So it doesn't matter if it's a co-secreting adenoma or if the patient even has a contralateral aldosterone-producing adenoma. I need to take out the cortisol secreting factory. So we don't do ABS in a patient who has both primary aldo and subclinical Cushing's or clinical adrenal dependent Cushing's.
Thank you. Last question. Would we do plasma metanephrine for myolipoma if the patient hypertensive? Would you do it as screening? If patient is hypertension? No, you will not do.
A myolipoma cannot make catechols. And again, we're talking about a typical myolipoma like I showed today. I would not screen for FEO.
Even if he's hypertensive?
Correct.
If the patient hypertensive and you don't know what it is. Okay.
Can't be FEO.
Okay. I have no more questions. And with that, we go to conclude this session. I would like to thank you very, very much, Professor William Young. It was great. And I will thank our colleagues, the participants, and we will have a break now. So we'll go for 15 minutes. We will come back, inshallah, by 7:45 according to Oman time and 6:45 according to Saudi Arabia time, inshallah, to start the other session with thyroid. So thank you very much, all participants. I just remind you that this is actually accredited by Dubai Health Authority, and you will get, inshallah, your certificate by the end of the course, the 3-day course. Professor William Young, thank you very much. We appreciate your participation.
Thank you, Bill.
Thank you, Dr. Ali.
Okay, good afternoon, good evening. Today we will have the second session of thyroid disorder. Nigel Johan, he will be chairing the session, and Prof. Elizabeth Pierce, she will be presenting thyroid disorder. She's a professor of medicine, section of endocrinology, diabetes, and nutrition, endocrine fellowship program director, and Boston University. Welcome, Prof. Elizabeth.
Thank you. It's a pleasure to be with you. Should I share my slides here?
Yes.
Yes. Okay. So thank you. It's a pleasure to be with you. Good evening to everyone. I want to start by acknowledging the work of Dr. Stacy Handler, who's one of my endocrine fellows who worked with me to develop some of these questions. So to jump in, our first patient is a 35-year-old who comes to clinic for follow-up of Graves' disease. At presentation a month ago, her lab values were a TSH that was fully suppressed. Free T4 is 4.37, total T3 is 430, her TSI is elevated at 340%, so thyroid stimulating immunoglobulin, and she was started on methimazole 20 milligrams daily 3 weeks ago. Today, she's reporting a foreign sensation in her eyes with tearing, diplopia, and some pressure behind the eyes. She has no throat pain, arthralgia, or fever. On exam, she's got an enlarged thyroid, some mild periorbital edema, and a fine tremor of her outstretched hands. There's no jaundice, and she tells you she's not planning pregnancy. Her lab results are an AST of 105, ALT also elevated at 186. Her TSH remains suppressed. Free T4 is 2.85, and her total T3 is 246. Which of the following is the next best step in her management? Do you want to discontinue methimazole and start her on PTU? Continue the current dose of methimazole, 20 milligrams daily? Decrease the methimazole to 10 milligrams daily? Or refer her for radioiodine ablation? All right, so very, very mixed bag here of what you selected, but most of you picked the answer that is the one I had in mind. So I would favor in this circumstance continuing methimazole 20 milligrams daily, and let me walk you through why. What I wanted to do with this question is just to remind you to recognize that liver function test abnormalities are very common in untreated hyperthyroidism. So this is a patient who has Graves' hyperthyroidism. She's improving, but is still hyperthyroid on methimazole. And there's not really a rationale for decreasing her dose at this point because her peripheral hormones are still quite elevated. She's not an optimal candidate for radioactive iodine treatment, given some active eye disease. And important to note that both PTU and methimazole, can be associated with hepatotoxicity. This is more frequent with PTU. It's about 2.5% of patients, whereas with methimazole, it's 0.4%. And remember also that rarely we can see fulminant hepatic failure with PTU, not with methimazole. So based on the fact that PTU is actually more hepatotoxic, there's really no rationale for somebody with elevated transaminases like this patient to switch from methimazole to PTU. With both of these medications, the highest risk for seeing hepatic injury is going to be in the first 90 days after initiating antithyroid drug. But very importantly, transaminase elevation is common in hyperthyroid patients, and it generally gets better as the hyperthyroidism resolves. So in fact, with antithyroid drug treatment, most of these patients get better. And it's for cases like this one that we actually recommend getting baseline liver function tests before you start the antithyroid drug treatment. This is, I think, a very clinically useful paper to know about. It's a systematic review that looked at liver function tests in patients who were hyperthyroid before and after treatment with antithyroid drugs. And what they found is that the majority of patients, more than half at baseline from their untreated hyperthyroidism, will have at least one liver function test abnormality. Usually it's a transaminitis. And most of the time, that actually gets better on antithyroid drug, even when the baseline liver transaminitis levels are 5 times upper limit of normal. So in this patient, it's safe to keep going. I would just monitor the liver function testing. Our next patient is a 32-year-old who's sent for follow-up of a right-sided thyroid nodule. And his nodule is first assessed 5 years ago after it was noted on palpation at a routine physical exam. There's no family history of thyroid cancer, no personal history of head or neck radiation treatment. He underwent an ultrasound-guided fine needle aspiration biopsy initially 5 years ago, which was read as benign. The nodule was biopsied a second time 3 years ago because it had grown from 1.8 to 2.9 centimeters in maximal dimension. The repeated biopsy was again read as benign. He tells you he has no compressive symptoms, and his serum TSH is 1.42. This is his ultrasound today. His nodule is now 3.6 centimeters, about the same as a year ago, and there's no concerning cervical lymphadenopathy. So, what's the best next step for this patient? Is it ultrasound-guided core biopsy? Is it thyroid lobectomy? Should we repeat an ultrasound-guided fine needle aspiration biopsy? Should we repeat the ultrasound in 6 months, or should we simply continue monitoring for compressive symptoms? Oh, good. You all got this, or many of you got this. 59% got this right. So let me just walk you through this quickly. We have a patient who has a nodule that is growing over time, but I hope that you recognize that that nodule did not have particularly concerning features on ultrasound. Mostly isoechoic with some cystic components, nice smooth margins, no hyperechogenic foci. So a nodule with no hugely concerning features, which has now been biopsied twice and was benign twice. Important to recognize that the likelihood of a false negative result on a fine needle aspiration biopsy is about 3%, but the risk that you biopsy the same nodule twice and have 2 false negative results is effectively 0. Also important to recognize that the risk for thyroid cancer does not differ in nodules with low risk characteristics between those that grow and those that don't. So if it is not concerning on ultrasound, the fact that it's growing over time actually should not raise huge red flags. So I would say that we don't necessarily need to repeat an ultrasound at all, although you could, it wouldn't be wrong, but we certainly don't need one in 6 months when this has been stable for the last year. There's really no reason for core biopsy. Nobody really chose that option. Lobectomy would be required if he developed compressive symptoms, but he has none right now. So I would argue that the most important thing for him is going to be continuing to monitor for those compressive symptoms and to make sure he knows what to look for, because that might trigger, thyroid surgery or perhaps radiofrequency ablation. But the ultrasound findings themselves are not ever really going to trigger another biopsy, and we're really not concerned about malignancy in this patient. Our next case is a 25-year-old man with a history of Hashimoto's thyroiditis. He's on levothyroxine 100 micrograms daily, and he presents to his primary care physician for workup of generalized edema. He'd been on a stable dose of thyroid hormone for 6 years. His serum TSH had been consistently in the reference range. A few weeks ago, he notes that he had an upper respiratory illness. He also tells you that his mother has a history of Hashimoto's and also of celiac. On lab testing, his TSH is elevated at 17.1 with a low free T4 of 0.5. Total cholesterol is 299, triglycerides are 490, serum albumin is 2.7, and his urinalysis shows 2.2 grams of protein per gram creatinine. So which of the following is the most likely etiology for his abnormal thyroid function tests? Is it malabsorption? Is it nephrotic syndrome? Is it antibody interference with the free T4 assay? Is it medication non-adherence or heterophilic antibodies affecting the TSH? Okay, the majority of you got this one right. So this was, in fact, a patient with nephrotic syndrome. And just an important thing to have in your differential. So always important in our patients who are refractory to treatment for hypothyroidism, who need huge doses or who have a sudden unexpected increase in TSH on treatment, to think about what the underlying potential causes could be. In this patient, I gave you a bunch of clues as to what the underlying etiology was. So in nephrotic syndrome, remember that when protein is lost in the urine, that includes thyroxine binding proteins with the hormone still bound. So these patients will actually lose thyroid hormone in the urine and can become hypothyroid. Clues to the diagnosis in this patient are his generalized edema, low serum albumin, high lipid levels. And typically in a patient like this, you'd expect if there's a reversible cause of the nephrotic syndrome that his levothyroxine dose requirements probably would go back to baseline as the proteinuria resolves. Important always to think about medication non-adherence, which is certainly going to be the most common reason for hypothyroidism that's not responding to treatment. Also important to think about celiac disease and other causes of malabsorption as a cause of an unexpected TSH elevation, failure to respond to levothyroxine, but this wouldn't, in this patient, explain the stigmata of the nephrotic syndrome. Also important always to think about whether your assay results are likely to be correct. In this case, I don't have a strong suspicion that they're inaccurate because the TSH and the free T4 levels are concordant with each other, making antibody interference with either of these assays unlikely. But remember, there are patients who can have a falsely elevated serum TSH due to heterophilic antibody interference or HAMA interference in patients measured with a TSH immunoassay. Patients with these antibodies floating around in their serum can develop kind of a link between the capture and signal antibodies for the immunoassay, even when the antigen like TSH is not around. So again, you get a false elevation. Most of the TSH assays these days do have some sort of washing steps that are built in that try and limit this interference. Also would note that antibodies to thyroid hormone can occasionally cause artifactually elevated thyroid hormone levels. They don't cause artifactually low ones, but the free T4 in this case is low. Our next patient is a 62-year-old woman. She presents for evaluation of abnormal thyroid function. She tells you that when she was 30, she underwent total thyroidectomy for benign goiter. And since then, she's been treated with varying doses of levothyroxine by multiple different providers, but she reports that none of her doctors have ever been able to get her thyroid blood tests to normalize. Right now, she's taking 150 micrograms of levothyroxine daily. She tells you also that her son was recently diagnosed with hypothyroidism. She's taking her thyroid hormone before breakfast every morning on an empty stomach. You call the pharmacy and they confirm that she's really picking up her levothyroxine refills consistently every month. She incidentally had a brain MRI done recently for headache, and this was read as normal. Here are her thyroid function tests over the last year on varying doses of levothyroxine. Important to note that the TSH results were not altered by serial dilution of the serum. So TSH, you can see, has been persistently elevated, ranging between 20.6 and 38, with a free T4 that has been ranging between high normal and frankly elevated up to 3.2. What's the most likely reason for these abnormal thyroid function values? Does she have a mutation in her thyroid hormone receptor beta gene? Could it be a mutation in her thyroid hormone receptor alpha gene? Does she have a pituitary adenoma? Is this, again, heterophilic antibody interference with the TSH assay? Or is this a case of medication non-adherence? All right. Most of you voted for heterophilic interference with the assay, and this is unequivocally a hard question, but I wanted to make you think about some things that maybe turn out more on boards tests than they do in clinical practice. So the correct answer here actually is, I think this is a patient who has a mutation in thyroid hormone receptor beta. So she has thyroid hormone resistance. Let me walk you through this. So first of all, again, we just said that medication non-adherence is a very common reason for people who don't respond to thyroid hormone therapy in hypothyroidism. In this case, though, although sometimes you see kind of discordant TSH and free T4 values in patients who don't take thyroid hormone for a while and then take it right before their visits, you wouldn't really expect to see the very markedly elevated free T4 with the very markedly elevated TSH. It's just not a pattern that quite fits this scenario. And we've checked with the pharmacy, which I usually do, and actually made sure that the patient is picking up the refills. Pituitary adenoma could explain these thyroid function levels in somebody, post-thyroidectomy who's on thyroid hormone replacement. But it's less common than the TSHR beta resistance. It's a 1 in a million diagnosis. And mostly, although not always, when there is disease severe enough really to be clinically apparent and probably to drive the TSH levels to this range, I would expect there to be a macroadenoma in the pituitary, and so this should have been visible on the patient's MRI. We talked about the HAMA interference with TSH assay, and again, something you unequivocally want to think about in any patient where you've got discordance between, the TSH and the peripheral hormone. But I gave you the factoid in the stem of the question here that this patient's serum had been serially diluted and the serum TSH levels didn't change. So this is the test you want your lab to do when you think perhaps there might be artifactually elevated TSH levels due to this assay interference. And the idea is that if you've got these antibodies floating around in the serum that are interfering with the assay results, as you dilute the serum, you should have a consistent TSH level if the number is real that you're measuring. But if this is artifactually elevated TSH due to this antibody interference, as you dilute those antibodies out of the serum, you'll start to get nonlinear results. So we didn't see that in this patient. We've excluded the possibility of assay interference. So then I want you to think a little bit about thyroid hormone receptor. Again, not something we think about so routinely in clinical practice, but important to remember that we have alpha and beta thyroid hormone receptors. And they are expressed differentially in different tissues. So the pituitary, hypothalamus, and liver predominantly express the beta receptor, whereas other thyroid hormone receptive tissues like brain and heart and gut and the musculoskeletal system predominantly express alpha. And so if you remember that, you can sort of work your way through what you would expect to see in somebody who's resistant because they have a mutation in one of these two types of receptors. So this is a mutation in thyroid hormone receptor alpha. I'm showing you the images from the index case that was reported in the New England Journal about 10 years ago. So these patients have tissue-specific hypothyroidism in the alpha selective tissues. So they have effects on growth, the skeleton, muscle, they get constipation, they have intellectual deficits because the parts of the body that are alpha receptor specific are hypothyroid. So that's brain and musculoskeletal system and the gut. But their pituitary hypothalamus are actually normally responsive because they mostly express the beta receptor. And so thyroid function tests in these patients are normal. You have to really think about the diagnosis. By contrast, the patients with the TR beta resistance, like the patient in the vignette I've just given you, they have they're able to sort of to be responsive to thyroid hormone in the alpha expressing tissues, but not in the beta expressing tissues. So it's a flip image of what I just showed you. This is rare. It's 1 in 40 to 50,000 live births. It's an autosomal dominant mutation, but 20% of these are de novo mutations. So sometimes, but not always, you're going to get a family history. The thyroid function test pattern in these patients is elevated T4, T3, and TSH, which is what we saw in this patient. The TSH is either elevated or sometimes it's inappropriately normal. And so what you see is goiter, because that TSH from the pituitary is going to be stimulating thyroid enlargement. The wrong response is what this patient had was thyroidectomy. It's not really going to help manage the patient. They get tachycardia, they get attention deficit hyperactivity disorder or anxiety from the sort of selective hyperthyroidism in the brain. Sometimes, but not always, you see effects on growth and development and short stature. On a board test, attention deficit hyperactivity, goiter, palpitations with this funny pattern of thyroid tests, or when you see this in the clinic, should trigger your suspicion. Our next patient is a 34-year-old. She has palpitations, heat intolerance, tremor, irregular menses. On exam, she's got a palpable, non-tender 3-centimeter right-sided thyroid nodule. Her TSH is fully suppressed. The free T4 is elevated at 3.1. The total T3 is elevated at 340. She's TPO antibody negative, and her thyroid stimulating immunoglobulin is undetectable. This is her radioactive iodine uptake and scan. You can see that there's uptake on the right exclusively, and her radioactive iodine uptake is 28% at 24 hours. She tells you she wishes to avoid the need for lifelong medication. So given that, what is the most appropriate therapy for this patient? Should we treat her with radioactive iodine, with ethanol ablation, methimazole, thyroid lobectomy, or radiofrequency ablation? All right, and you're kind of mixed here. And again, this is hard. I would argue that the best choice is answer E here. I'll talk you through this, but answer D is not wrong if you don't have radiofrequency ablation available in your center. Many of us do not. So this is a patient I hope you recognize with a toxic nodule. So she's got a single toxic nodule, and all of the treatment options could cause her to become euthyroid. None of them are the wrong answer if you're just trying to get her to euthyroidism, because these should all be effective. If we treat her with thyroid lobectomy, there's a very high cure rate. It's effectively, treatment failure of 0. And with, a remaining lobe in place, she's at about a 2.2 to 3% risk for postoperative hypothyroidism, based on the literature for how people do after surgery for toxic nodules. Antithyroid medication will render her euthyroid, but toxic nodules don't remit, so she's going to need that forever. And she's told you that her major priority is avoiding lifelong treatment. So that's not the best choice. Ethanol injection can be useful for cystic nodules. It has been reported to be effective as treatment for toxic adenoma, but probably really not the first choice treatment, because there are high rates of thyroid pain, other complications here, and we have a lot of other options that are probably better choices on the table. Radioactive iodine treatment probably also will be effective for a toxic adenoma. Cure rates of 90% or above, but there's actually a progressively increasing risk of hypothyroidism over time, so that if you follow these patients who get radioactive iodine treatment for a single toxic nodule for out to 20 years, up to 60% actually may at some point develop hypothyroidism. That risk is going to be higher in patients with underlying thyroid autoimmunity, and of course, in patients who are TPO antibody positive. No matter what you choose, they may ultimately become hypothyroid. Radiofrequency ablation is kind of the new kid on the block for treatments here. The literature suggests very low reported complication rates and very low risk for permanent hypothyroidism, because you're really not touching the surrounding thyroid parenchyma if this is done correctly. So the only cases in the literature of hypothyroidism following radiofrequency ablation for a toxic nodule are typically, again, in those patients with baseline thyroid autoimmunity who probably would have progressed to hypothyroidism anyway. But recognize I don't have this at my own center. I have it across town in Boston. This is not widely available around the world. So if you don't have the radiofrequency ablation, the best chance of rendering this patient permanently euthyroid, not needing any medications, is going to be lobectomy. Our next case is a 30-year-old who's 10 weeks pregnant. She's admitted for severe nausea and vomiting. She's got no personal or family history of thyroid disease. On exam, her blood pressure is 1/8/60. Her heart rate's 112 beats per minute. Her thyroid is not tentative palpation. It's not enlarged, and she has no bruit. She has a mild tremor. She has no exophthalmos. Her labs are as follows. The TSH is 0.01. Her free T4 is elevated at 2.8. Her total T3 is elevated at 280. Her thyroid stimulating immunoglobulin is negative. What's the most appropriate next step in her management? Do we want to obtain a radioactive iodine uptake and scan? Do we want to start her on PTU, 50 milligrams 3 times a day, methimazole, 5 milligrams a day, atenolol, 25 milligrams a day, or just repeat the thyroid function tests in a few weeks? All right. You mostly got this one right. I finally gave you a question, so it's a little easier to sort through. So yes, I'd recommend that this patient just have follow-up testing in a few weeks. Important to remember that in women of reproductive age in general, the most common cause of hypothyroidism is going to be Graves' disease. But specifically in the first trimester of pregnancy, the most common cause of hyperthyroidism is not Graves'. It's this entity called gestational transient thyrotoxicosis, or GTT, which is basically just HCG-mediated stimulation of the thyroidal TSH receptor. As the name implies, it's a transient entity. As the HCG levels come down after week 10 or 12 of gestation, the hyperthyroidism is going to spontaneously resolve. So we see gestational transient thyrotoxicosis more frequently in patients with very high HCG levels, for example, in twin and triplet gestations. We also often see it in patients with a lot of nausea and vomiting, because that is also HCG mediated. So we don't want to give this patient anti-thyroid drugs. We don't treat gestational transient thyroid toxicosis with that because it's going to get better on its own. And because those anti-thyroid drugs have some teratogenicity when we use them in the first trimester, we don't want to use them when it's not essential. We don't need a radioactive iodine uptake and scan to make the diagnosis for this patient. We already have a negative thyroid stimulating immunoglobulin. We know this is not Graves. And we could treat her with short-term beta blocker just to help with thyrotoxic symptoms if she's reporting them. But if you're going to do that, you have to remember that in pregnancy, not all of the beta blockers are equal in terms of safety. That atenolol is an US FDA category D drug. It's less safe than other options that can be used in pregnancy for beta blockade, which would include propranolol or labetalol. Our next case is an 81-year-old man. He's referred by his primary care physician for evaluation of thyroid function. He notes some mild fatigue, occasional constipation, and some hip pain. He's independent in his activities of daily living. He has an active social life in his retirement community. On exam, his blood pressure is 135/80. His heart rate is 65 beats per minute, weight 72 kilograms. He has a regular heart rate and rhythm on exam. His thyroid is normal in size without palpable nodules or tenderness. And he has these thyroid function tests. So 6 months ago, his TSH was 7 and his free T4 was 0.9. Today, his TSH is 8.2, his free T4 is 0.8. You get a TPO antibody measurement, and that is negative. So what's the next best step in the treatment of this patient's thyroid condition? Should we repeat the labs in 3 to 6 months, obtain a thyroid ultrasound, start him on thyroid hormone 25 micrograms a day, start levothyroxine 100 micrograms a day, or start him on T3, T4 combination therapy with levothyroxine and liothyronine? So the majority of you wanted to do what I would do in this scenario, which is just to watch. And I wanted to think through, how we manage subclinical hypothyroidism, in the elderly. So a couple of things to think about here. One is, and I'll show you the data for this in just a moment, we know there's a physiologic rise in TSH with aging. So although most labs don't provide age-specific TSH reference ranges, know that somebody in his 80s may have kind of a higher upper limit, and not really sure that a TSH of 7 is unequivocally abnormal. Also, we have a very good randomized trial in the literature published in the New England Journal in 2017. This was the TRUST trial that randomized patients who were age 65 or older with baseline subclinical hypothyroidism to levothyroxine versus placebo, and they saw no benefit for symptoms, also suggesting that treatment may not be so helpful. We have observational data that do strongly suggest that subclinical hypothyroidism is associated with increased cardiovascular risk. But it's important to note that this is more pronounced at TSH levels greater than 10, and also that at least right now, we don't have randomized trial data demonstrating a benefit of treatment of subclinical hypothyroidism specifically for cardiovascular risk. Thyroid ultrasound not indicated in the routine management of hypothyroidism as somebody who doesn't have palpable nodular goiters. And these are the data, again, for TSH. These are data from the US NHANES survey. When you exclude individuals who are pregnant, have antithyroid antibodies, overt thyroid dysfunction, or taking any thyroid containing medications, what you see is a rightward shift in the TSH curve as people age. So for people in their 20s, upper limit of normal for TSH is maybe around 3.6, or it may be as high as about 7.5 in somebody in their 80s. So for this patient, I think probably important to avoid over-treatment, avoid unnecessary treatment with levothyroxine in older persons where we don't have trial evidence for benefit when hypothyroidism is mild and where we have the potential to do some harm. Our next case is a 57-year-old woman. She underwent total thyroidectomy for a 3-centimeter left-sided nodule, which was read as Bethesda 6 or malignant on cytopathology. Surgical pathology showed a 3.1 centimeter papillary thyroid cancer. It was classical variant. 3 of 9 resected left level 6 lymph nodes were positive for tumor, with those tumor foci all being microscopic, less than 0.2 centimeters in largest dimension. There was no tumor invasion of the tumor capsule. Surgical margins were negative. There was no venous or lymphatic invasion, no perineural invasion. She was started on thyroid hormone at the time of her surgery. 6 weeks postoperatively, her serum thyroglobulin is 0.3, and she's thyroglobulin antibody negative. So what would you like to do for this patient's management? Is it no radioactive iodine with an initial TSH goal that's in the low end of the normal range, 0.5 to 2? No radioactive iodine, but initial TSH suppression to 0.1 to 0.5. 30 millicuries of radioactive iodine, either with a TSH goal of 0.1 to 0.5 or less than 0.1, or 100 millicuries of radioactive iodine with full TSH suppression. All right, and kind of split decisions here. But the majority of you actually picked the answer that I would have favored. So which would be no radioactive iodine, and she probably doesn't need TSH suppression. So, you know, the key here is to understand postoperative risk stratification for differentiated thyroid cancer. I will tell you, I was at the American Thyroid Association meeting last week, and they presented data for the new thyroid cancer guideline it's going to be coming out probably in the next 6 to 8 months. What I tell you today is still correct in the new guideline regarding the risk for the treatment for low-risk differentiated thyroid cancer, but there are going to be some changes to that ATA risk stratification system coming up soon to watch out for. So important to note that radioactive iodine ablation does not prolong survival in low-risk patients. It does confer some risk for secondary malignancies, and in low-risk cancers, there's really no benefit of TSH suppression. And in fact, in the upcoming revision of the ATA guidelines, they are really kind of de-emphasizing TSH suppression a bit and not trying so hard to keep the intermediate risk patients TSH suppressed. So this is a very nice table that comes from a recent JAMA review from Laura Bokai and colleagues. And I would focus on the low risk section of this table, which is where our patient is. This is where happily most of our patients wind up in terms of their risk stratification, and this is stratification for risk of persistent or recurrent disease. This is not stratification for mortality, which is the AJC staging system, which is a separate entity. So this patient has no local or distant metastases, no macroscopic tumor left behind, the margins were clean, no aggressive histology like columnar or a tall cell variant, no vascular invasion. We don't know about radioactive iodine uptake outside the thyroid bed, but we usually don't know about that in low-risk patients because they really aren't the patients who should be getting radioactive iodine treatment. She has 5 or fewer pathologic lymph nodes, and they're all small, kind of micrometastases. So unequivocally, current guidelines and revised guidelines that are going to be coming out for this patient would not recommend radioactive iodine. This table interestingly suggests initial mild TSH suppression if the thyroglobulin is detectable, and low normal if it's undetectable or if lobectomy is performed. But in fact, as I've told you, current guidelines actually would not recommend initial TSH suppression for a low-risk patient. I don't do that in my own management, and the upcoming guidelines unequivocally are not going to recommend that as a strategy for low-risk patients. Our next patient is a 65-year-old man who was started on amiodarone 2 months ago for recurrent ventricular tachycardia. Prior to starting the amiodarone, he had the following thyroid function tests. So TSH was 3.2, free T4 normal at 0.78. On follow-up today, 2 months later, he reports no change in weight, no change in energy level. He's not having any palpitations. On exam, his heart rate is 67 beats per minute. Blood pressure is 138/78. He has no tremor. His thyroid is normal in size to palpation, and there are no nodules to palpation. Repeat thyroid labs show a free T4 that's elevated at 2.1 and a TSH that's elevated at 6.2. What's the next best step for this patient? Should we get pituitary MRI? Should we repeat the labs in 4 to 6 weeks, get a thyroid ultrasound, measure TSH receptor antibodies, or start him on levothyroxine? All right. Most of you got this right. Happy to see. So yes, I would recommend just following with repeat labs. So important to remember that amiodarone can do lots of interesting things to the thyroid. Depending on background iodine intakes in a population, and it sort of can cause hyperthyroidism in about 5% of treated patients and hypothyroidism in about 7%. But even in the people who don't develop thyroid dysfunction on amiodarone, remember that the amiodarone itself can alter thyroid lab testing. So amiodarone is a potent inhibitor of deiodinases that convert T4 to T3. And it actually can perhaps induce kind of tissue-specific hypothyroidism in the heart. And maybe that's actually why blocking the TSH receptor binding to thyroid hormone-sensitive tissues like heart, that maybe is why amiodarone is such a potent medication as an antiarrhythmic. What you typically see in somebody on amiodarone is that the T4 and free T4 may rise a bit, and the T3 or free T3 may fall a bit because of that potent block of the T4 to T3 conversion. TSH typically will remain the same in somebody's euthyroid with the footnote that what you can see in the first 3 months of therapy, which is shown here in this older study, is that as the T3 levels in the serum initially fall due to the decreased T4 to T3 conversion, there can be kind of a transient rise in TSH as the system kind of comes to a new equilibrium. And so I think that's what we're seeing in our patient. He's newly started on amiodarone. He's had a slight rise in his free T4 because it's not getting converted to T3 as readily. Because there's a little bit less circulating T3 around, he's still equilibrating. The TSH is a little bit elevated. So most likely this is somebody who's euthyroid, although I would certainly follow the thyroid labs in another few weeks to make sure that's the case. And again, remember that the normal reference ranges may not fully apply in amiodarone-treated patients. T3 after that initial 3-month period should actually follow the normal reference ranges, but the T3 may be just a little bit lower than normal. Free T4 and total T4 may be just a little bit higher. On Doppler ultrasound, so in patients with amiodarone-induced thyrotoxicosis, ultrasound can actually be helpful because it can help you differentiate between type 1, which is iodine-induced hyperthyroidism, where there's often increased thyroid vascularity, either across the gland or in toxic autonomously functioning nodules, or absent vascularity in a gland that has type 2 amiodarone-induced thyrotoxicosis, which is a destructive thyroiditis. But this patient is not thyrotoxic, so we don't need to do ultrasound. It's not going to help us. Pituitary MRI, which I think nobody chose, is not needed because we have a better explanation for the discordant thyroid function test, and we'd expect them to normalize. And again, this patient is most likely euthyroid, so I wouldn't start him on levothyroxine now, although if you check his labs in a few weeks and the TSH is higher, then perhaps he truly is developing amiodarone-induced hypothyroidism and might warrant therapy. Our next patient is a 60-year-old woman. She presents for evaluation after a thyroid nodule is noted incidentally on chest CT. Thyroid ultrasound reveals a solitary right-sided nodule. There are no concerning lymph nodes. She has no family history of thyroid cancer. So here is her nodule on ultrasound. Based on these characteristics, what category best describes the risk of malignancy in this nodule? Is it less than 1%, less than 3%, 10 to 20%, or 70 to 90%? Okay, kind of a mixed bag here as well. So, and sometimes just seeing a still image, it's a little bit hard to tell what's suspicious and what's not. And it's easier if you're doing it yourself and you can see this in real time. But I would say this is probably a complex nodule. Parts of it that are more solid are actually have some microcystic areas, and probably this is sort of complex and spongiform. Definitely this nodule has clearly defined margins. So this pattern strongly suggests that there's a low risk of malignancy in this nodule. As for thyroid cancer, there are going to be new guidelines coming out soon for thyroid nodules from the ATA. I saw this presented also last week at the ATA annual meeting. And just be aware, there actually are some fairly significant changes coming in recommendations for how we risk stratified nodules. But I will note that the answer to this question actually is not going to shift. So the current ATA guideline uses sort of this pattern-based algorithm for defining risk stratification. There are other risk stratification systems out there. There's TIRADS, there's a Korean TIRADS, there's an Italian TIRADS, there are many systems. And I think you just need to use a system. I don't think there's any evidence that one is particularly better than any of the others. These are all effectively looking for the same features that confer higher or lower risk of malignancy in thyroid nodules. And then we'll give you some guidance as to what does and does not need biopsy based on size. So high suspicion patterns, hypoechoic nodules, irregular, lobulated, spiculated borders, punctate echogenicities. The upcoming guidelines are no longer going to rate these high suspicion nodules as having 70 to 90% risk of malignancy. They're going to be nodules with a greater than 50% malignancy. And that's based on newer data, and it becomes a bit more of a spectrum. They are going to continue to call nodules that are purely cystic, as we see at the bottom, benign. And I think the one I just showed you, I would argue, falls into the very low suspicion category. You could argue it's the low suspicion, but it's certainly not as high a malignancy risk as 10 to 20%. Our next patient is a 67-year-old woman who presents to clinic for follow-up of papillary thyroid cancer. She underwent total thyroidectomy 15 years ago. 5 years ago, a neck ultrasound demonstrated an abnormal appearing right level 4 lymph node, which measured 0.9 centimeters. At the time, that was biopsied, and it was found to be papillary thyroid carcinoma. She was also at that time found to have numerous pulmonary nodules measuring 1 to 2 millimeters in size. She's been treated with radioactive iodine 3 times over the years. Her most recent treatment was a year ago, and at the time of that treatment, there was no uptake on her post-treatment scan. Serum thyroglobulin levels over the past year have risen from 100 to 800. She's thyroglobulin antibody negative. Recent neck ultrasound shows that her previously biopsied right level 4 node is stable in size, and there's no additional concerning cervical lymphadenopathy. Her chest CT continues to show multiple lung nodules, but the largest has grown in the last year and now measures 1.5 centimeters. Biopsy of that largest lung lesion shows papillary thyroid cancer. Genetic testing is positive for BRAF V600E. Her serum TSH is 0.07, free T4 is 1.6 on levothyroxine. She tells you she's feeling more tired and short of breath over the past few months. She works full-time, independent in activities of daily living. What should be the next step in her treatment? Should we give her another dose of radioactive iodine? Should she undergo next dissection? Should we start lenvatinib, or should we increase her levothyroxine dosing? All right, most of you opted for lenvatinib, and I think that's probably the right thing to do here. So let me again walk you through this. I wanted you to think about indications for systemic therapy in advanced differentiated thyroid cancer. So first, in evaluating patients with advanced thyroid cancers, we need to think about whether the lesions, the tumors, are radioactive iodine avid or radioactive iodine refractory. But in this patient, there was no uptake after her last radioactive iodine treatment, and she's had a subsequent rise in thyroglobulin. So I think we conclude that she is radioactive iodine refractory at this point. Neck dissection is unlikely to be beneficial, although we know that she's got a small lymph node that's sitting there that's positive for papillary cancer. This is 0.9 centimeters. It's stable. It's unlikely to be causing symptoms. Her TSH is already at goal. I mean, in high-risk patients, TSH suppression is helpful in reducing risk for morbidity and mortality, but she's less than 0.1. I would argue that increasing the thyroid hormone dose further probably doesn't have additional benefit. And so here we have to think then about indications for considering systemic therapy in differentiated thyroid cancer patients who are radioactive iodine refractory. So that list of indications includes progression of disease on cross-sectional imaging, so known structural disease that you can follow that's growing, symptomatic disease, and quite probably her increased shortness of breath is related to her pulmonary metastases. Tumors affecting an organ here would be lung or also lymph function like bone fracture, or tumors that are 1.5 centimeters or larger. So this is a table from the recent review. I showed you a table from earlier, but I think this is quite a nice review, and I would commend this to you, that looks at systemic treatments and targets that are currently FDA approved for patients with differentiated thyroid cancer, anaplastic thyroid cancer, medullary thyroid cancer. It is very helpful in deciding to treat one of these patients with systemic therapy to understand what the underlying mutations are in the tumor, what's driving it, so that you know what it's likely to respond to. I gave you the option of lenvatinib for this patient, and that would be a reasonable choice. Had I given you the option of dabrafenib, which targets specifically BRAF mutations, that would also be a reasonable choice in this patient. So a 65-year-old man is referred for evaluation of thyroid nodule. It incidentally found on CT performed for lung cancer screening. A subsequent ultrasound showed a 1 centimeter solid hypoechoic thyroid nodule in the mid-right lobe. This has smooth margins. It's not near the edge of the thyroid capsule or any vascular structures. There's no evidence of extrathyroidal invasion. There are no abnormal cervical lymph nodes, and fine needle aspiration biopsy is done and read as Bethesda 6 or malignant. He's got a long smoking history. He's on chronic home oxygen for COPD, and he doesn't want to have surgery. He lives close to the hospital. He comes consistently to his outpatient appointments. What's the next best step in the management of his thyroid cancer? Should we repeat the ultrasound in 6 months? Should we send him for total thyroidectomy? Should we send him for right thyroid lobectomy? Should he have radioactive iodine treatment? or should we measure serum thyroglobulin before deciding? All right, and the majority of you wanted to repeat the ultrasound in 6 months, and that's what I would do here also. So he has a small papillary thyroid cancer. It's not really a microcarcinoma because it's a centimeter in size, but he's really not a very good surgical candidate, and he wants to avoid surgery. So I would say the one answer that's kind of unequivocally wrong is total thyroidectomy. We really shouldn't be doing total thyroidectomy for 1 centimeter cancers in this day and age. It incurs too much risk for too little benefit. But even the lobectomy might be risky in this patient given his COPD. He's one of those patients who may not be extubatable after surgery. We can't give him radioactive iodine treatment because he's got a thyroid gland in place. His normal thyroid is likely to take up most of the radioactive iodine, and he might have a roaring post-treatment thyroiditis from that, but it's unlikely to actually address the tumor. And there's no role for thyroglobulin monitoring because he's got an intact thyroid in place. It's really not going to help you. But he is an excellent candidate for active surveillance for his cancer with ongoing ultrasound monitoring. Now, this is something that was mentioned as one line in the current 2015 ATA thyroid cancer guidelines that said you can do this in patients where surgery is not an option or not desired. The upcoming guideline is going to give a lot more guidance on this. And this, again, was presented last week, and I think we have a pretty good sense of what's going to be in the upcoming guideline. But it's not so different from some guidance that's actually already available. So patients who are sort of ideal patients for not having surgery when they're diagnosed with thyroid cancer include older individuals, because those under 60 are more likely to have a tumor progression, although it's not an absolute contraindication. These are just things you need to weigh in decision-making with patients. Ideally, smaller tumors. Some centers have protocols that suggest this is best for tumors less than 1 centimeter. Some places less than 1.5 centimeters, and I think that's where the new guideline is going to be. Some places maybe less than 2 centimeters, but smallish. Ideally, you don't want it to be right at the edge of the thyroid where it's sort of poised to invade into trachea or vessels or other structures. Ideally, you don't see evidence of extrathyroidal extension already on ultrasound. If you see that, that's probably not a good candidate for just monitoring without therapy. You don't ideally want to see lymph node metastases. You need to have patients who are comfortable with the concept of not resecting a thyroid and just watching it. And I've told you in the stem of the question that this patient is. You need to have them willing and able to come back for follow-up visits so you can monitor with ultrasound, and you need to have high-quality ultrasonography available in your center to do this effectively. So the ATA guidance is probably going to look a whole lot like what's already published from the Japanese Endocrine Society. And that's going to suggest that in patients where we know there's a small thyroid cancer and we elect not to pursue immediate thyroid surgery, that we will monitor with ultrasound periodically, initially perhaps every 6 months, and then spacing out to once every year or two if things are stable for a while. The indication for reconsidering this approach and for kind of pulling the trigger on sending these patients to surgery is an increase in the tumor diameter in any diameter of at least 3 millimeters. That's not quite what the Japanese guideline says, but that's what the ATA guideline is going to say. Or appearance of new lymph node metastasis. You can also, of course, always change plans and send patients to surgery if they change their preference, or if it turns out down the road that there's some other reason for neck surgery, like primary hyperparathyroidism, where the surgeon's going to be in the neck anyway. But important to note that serum thyroglobulin is just really not helpful in active surveillance protocols, and there's probably not a good reason to get it. This is a meta-analysis that was done in preparation for the upcoming revised ATA cancer guideline. So these are some of the data that inform what those recommendations are going to look like. And here they pooled data across 4 studies that prospectively followed patients in these active surveillance protocols. Again, these are selected patients who are selected for this. These are not randomized studies. But what they saw was that over 5 years of follow-up in the selected group, only about 5% of patients met that threshold where there was an increase in tumor diameter of at least 3 millimeters, and very few, less than 2%, wound up having lymph node metastasis over that period of surveillance. Our next patient is a 30-year-old. She's got a history of Graves' disease that's in remission. She presents for follow-up of her thyroid condition. She was initially diagnosed with Graves' hyperthyroidism 4 years ago, treated at that time with methimazole. She's been off the methimazole now for 2.5 years, and she's feeling well. She tells you she's actively trying to conceive and she wants to discuss preconception planning. On exam, her blood pressure and heart rate are normal. Her thyroid is normal to palpation, doesn't have a nodule or bruise. Her labs 3 months ago showed a mildly low TSH of 0.23 with a free T4 of 1.4. Today, her TSH is 0.18, free T4 is 1.3, and her thyroid stimulating immunoglobulin is mildly positive. So what's the next best step for this patient's management? Do we want to start her on PTU once she becomes pregnant? Do we want to start her on PTU now? Do we want to start her on methimazole now, but switch her to PTU when pregnancy is confirmed, or simply repeat thyroid function testing in 3 months? All right, most of you want to do what I would choose to do in this scenario also, which is just to watch, repeat labs in a few months. But this is sort of an opportunity to think a little bit about risks of subclinical hyperthyroidism, preconception and pregnancy, and also in general, sort of who's a candidate for therapy for subclinical hyperthyroidism in general. So first of all, there's no evidence that subclinical hyperthyroidism is associated with risk for fertility, although admittedly, there are not really great data for this. In addition, there are better data to suggest that subclinical hyperthyroidism in the pregnancy setting is not associated with any adverse pregnancy outcomes. So probably safe to observe it even if this patient were already pregnant. And as we've discussed before, PTU and methimazole are both teratogenic, and I'll show you the data for that in just a second. Also, subclinical hyperthyroidism sometimes spontaneously reverses. Often it's not going to do that if it's due to toxic nodules. We've already discussed that those don't remit, but often in Graves' disease, mild hyperthyroidism will get better, and that may spontaneously resolve in up to half of people. A predictor of something that's going to reverse on its own is a TSH that is not fully suppressed. And these patients can also, get worse. They can progress to overt hyperthyroidism, but the rate of that's about 5 to 7% annually. It's not actually all that high. The ATA hyperthyroidism guidelines sort of suggests, by and large, not treating patients who are younger than age 65 and are asymptomatic, and consideration of treatment in those who have, lower TSH, less than 0.1 persistently, or who have osteoporosis, who are older, who have cardiovascular risks, or who have symptoms. So this is not a patient who, excluding considerations around pregnancy, we would necessarily be starting on thyroid hormone anyway, because she's feeling fine and she's young, or sorry, anti-thyroid drug. We wouldn't start her on thyroid hormone. And then these are the data for the teratogenicity of the 2 anti-thyroid drugs. And I think these are important to know. Both PTU and methimazole can be associated with birth defects, and we have these 2 large registry studies that really inform us about that risk. So they're associated with different types of birth defects. With methimazole, often it's malformations of the musculoskeletal system or the GI tract, often things like choanal atresia, or sometimes aplasia cutis. It's an absence of a patch of skin. With PTU, the malformations are typically both less frequent and also less severe. So it's most frequently abnormal cystic structures of the head and neck, or abnormal development of the urogenital tract in a male fetus. Now, both of these registry studies showed the same pattern of birth defects with these 2 anti-thyroid drugs, but they showed different absolute risks. And to my patients, I like to quote the numbers from the Korean registry study, which is larger and which showed that the risk was a little bit lower. So in that study, for every 1,000 live births in women who were treated with anti-thyroid drug in early pregnancy compared to women who were not treated, you might expect to see about 8.8 additional birth defects with PTU, about 17 additional birth defects with methimazole. And unfortunately, women who got exposure to both of those anti-thyroid drugs in early gestation in the Korean registry study had children at risk for both birth defects. So if you opted to start anti-thyroid drug in this patient, and I would argue that it's not necessarily needed given her clinical parameters, but if this worsened and she needed treatment, probably best to start people on PTU if it's needed in early gestation or pre-pregnancy. There are going to be upcoming ATA guidelines on pregnancy as well. Lots of new guidelines coming next year, but we are not going to change that recommendation in the new guideline. A 35-year-old woman presents to clinic for evaluation of her thyroid condition. She's been trying to conceive without success for 18 months. She's planning in vitro fertilization. She has a family history of autoimmune thyroiditis and her maternal grandmother. On exam, she has a normal blood pressure and heart rate. She weighs 50 kilograms. Her thyroid is normal to palpation. She doesn't have any palpable nodules or tenderness. Her TPO antibody is positive and her serum TSH is 3.9. What's the recommended treatment for her thyroid condition? Is it no treatment? Is it low-dose levothyroxine, 100 micrograms of levothyroxine, selenium daily, or prednisone? All right, most of you wanted to do what I would choose to do in this circumstance, which is to not do anything and not treat, but let me again walk you through that. So we had recommended in the prior 2017 ATA thyroid and pregnancy guidelines to consider levothyroxine therapy in women who are euthyroid, TPO antibody positive in early gestation or preconception. However, since we published that guideline, we now have 3 randomized clinical trials in good journals that have demonstrated that when you start levothyroxine preconception in women who were TPO antibody positive and euthyroid, there is no benefit for clinical pregnancy rate of live birth, decreased miscarriage, decreased preterm delivery. And we know that from 3 studies. There's one published in JAMA in 2017 called Postal, one called Tablet, published in the New England Journal in 2019, one called T for Life, done in the Netherlands. It was published in Lancet Diabetes Endocrinology in 2022. So this is one of the few places in all of the thyroid and pregnancy literature where we have 3 reasonably large trials that are all concordant. And so the updated ATA guidelines are no longer going to recommend levothyroxine for TPO positive women, either in gestation or preconception. But I think it's important to note that what we do know is that these women who are TPO antibody positive are unequivocally at increased risk for becoming hypothyroid once they're pregnant or once pregnancy progresses. And so these are patients where if you know their TPO antibody status, although I wouldn't treat them upfront, I would monitor closely, especially in early gestation, as normally thyroid function needs to sort of ramp up a bit. And I would treat them, if they become hypothyroid. Trials have not evaluated serum selenium supplementation in the preconception setting for TPO antibody positivity. In euthyroid women. We have 3 very small trials that have evaluated selenium supplementation in early gestation, and they have had sort of conflicting results. They use different doses, but really no compelling evidence of benefit for selenium supplementation. ATA guidelines did and will continue to actually recommend against this because there's a little bit of evidence that perhaps selenium supplementation might increase risk for gestational diabetes. And benefit is really unclear. Guidelines also do and will continue to recommend against glucocorticoid therapy for TPO positive euthyroid women who are undergoing IVF. There are very, very limited tiny trial data. And you have to remember that up to about 10% of all pregnant patients are TPO antibody positive. So if we're advocating, high dose glucocorticoid therapy starting preconception or early gestation for enormous numbers of women, it's just kind of a scary thing to do in the absence of a really clear evidence for benefit and, the potential for really doing harm. So there is no recommendation to do that right now, but I think that's probably an area that needs additional study. Few more patients, we're almost done. A 37-year-old woman presents with a 4-month history of tremor, palpitations, irregular periods, and weight loss. She'd previously been healthy. She's not taking any medications. On exam, her thyroid is not enlarged and it's not tender, and she has no exophthalmos. So her lab results are a TSH that's fully suppressed, a total T3 that's elevated at 367, a free T4 that's elevated at 2.6. Her serum thyroglobulin is 76. Her thyroglobulin antibodies are negative. Her TPO antibodies are negative. She has a radioactive iodine scan done, an uptake and scan, and there's no thyroidal radioactive iodine uptake that's detectable. The day she has that done, she has a urinary iodine concentration measurement, which is normal at 104 micrograms per liter. So she started on a beta blocker. 3 months later, she returns. She reports that the palpitations have improved on the beta blocker, but her other symptoms persist, and her labs are essentially unchanged. So what is the next best step in her evaluation? Do we want to get thyroid ultrasound with Doppler? Do we want to measure TSH receptor antibodies? Do we want to measure an erythrocyte sedimentation rate, perform whole body radioactive iodine scan, or ask her about exogenous sources of thyroid hormone? All right. Most of you actually wanted to ask her about exogenous thyroid hormone, but I would argue the right answer here is the performing a whole body scan. And let me, again, walk you through why. So we know this patient doesn't have Graves' disease, right? Because she's got low radioactive iodine uptake. And so measuring the TSH receptor antibodies is not going to get us anywhere. So now we're thinking about the differential diagnosis for thyrotoxicosis with low radioactive iodine uptake, and there are several things on that list that you always need to keep in the back of your mind. The first are forms of thyroiditis, either subacute thyroiditis, which is painful, or the painless form of autoimmune thyroiditis. Now, this patient doesn't have any thyroid pain, so I don't think measuring the sedimentation rate is going to be helpful because I think it's very unlikely that she has subacute thyroiditis. If she has painless thyroiditis, ultrasound might help you a little bit because you could look at the vascularity and try and assess whether she has absent vascularity. But the problem here is this patient has been symptomatic now for several months, and the TSH has been suppressed and peripheral hormones elevated for several months. Thyroiditis resolves faster than this. Usually by about the 9 or 12-week mark, it's coming down. Usually patients aren't hugely symptomatic from their thyrotoxicosis either. So this, although it's what it was assumed to be the case, it's why she was started on a beta blocker after the initial scan and labs, probably not what she actually has, because this is not responding the way thyroiditis should. Most of you thought this was perhaps exogenous thyroid hormone, and that absolutely needs to be in the differential here. Sometimes it's intentional use of thyroid hormone, sometimes it's not. But we know that's not the case in her because we got a thyroglobulin measurement, which is 79. If she were getting exogenous thyroid hormone, she would be shutting down her own thyroid hormone production, and her thyroglobulin, therefore, would be very low to undetectable. So asking her about exogenous sources is not going to help in this scenario. So then we're sort of down to kind of a grab bag of a few things that this could be that we need to rule out. It's not drug-induced thyroiditis because she's not on medications. It's not iodine-induced hyperthyroidism, which is why I gave you the normal urinary iodine concentration the day of her scan. Very rarely, metastatic follicular thyroid cancer can cause low radioactive iodine in the neck, uptake hyperthyroidism. But those are patients with massive tumor burden. These are not people who walk in off the street and are feeling well. So really the only thing this could be, after excluding all these other options, is struma ovarii, where she's got teratoma in her ovary that has thyroid tissue that's functional. And in this scenario, you won't see uptake in the neck, but if you do a whole body scan, you'll actually see the uptake in the pelvis. So think about this. It's an unusual diagnosis, but you need to remember this is out there. Think about this when you see somebody where you think it's kind of garden variety inflammatory thyroiditis, but it doesn't get better. Or in women with low radioactive iodine thyrotoxicosis with a pelvic mass. Our next patient is a 73-year-old man who presents with very rapid enlargement of his left thyroid lobe over a 6-week interval. He reports difficulty swallowing, worsening pressure sensation in his anterior neck. On exam, there's a visible and palpable 7-centimeter left thyroid nodule. There's no stridor. Ultrasound-guided fine needle aspiration and core needle aspiration biopsy are done and read as anaplastic thyroid cancer. You order chest, abdomen, pelvis CT. You order whole body FDG PET CT. You're also going to have a discussion of goals of care and advanced directives. But in addition to all of that, what is needed most urgently? Should he go straight for debulking surgery, assessment of tumor BRAF V600E status, palliative external beam radiation, tracheostomy, or start larotrectinib? All right, and kind of a mixed bag here, but the answer I was aiming for was actually assessment of his BRAF status. These cases are hard. And the key thing about this is that when you first see somebody with anaplastic cancer, you have to move fast because these tumors grow sort of terrifyingly quickly. They can block airways, they can cause, really sort of devastating outcomes really fast. So you need to move very quickly once this diagnosis is made. Current guidelines from the ATA, current consensus conference data suggest that initial steps when you make this diagnosis, kind of pan image with cross-sectional imaging, so neck, chest, abdomen, CT or MRI, and also PET scanning, and you're looking for distant disease. Flexible laryngoscopy is going to be important because these patients can impede their tracheas fairly easily. You want to make sure that the trachea is patent. Brain MRI is suggested also, and spine MRI if there are any symptoms suggestive of spinal Mets. But also, very importantly, very early in the sequence, you want to get expedited assessment of the tumor BRAF V600E status. And I'll show you in a moment the algorithm for this. Surgery is sometimes helpful. Sometimes these are resectable, but just debulking surgery these days is discouraged because these things grow so fast that you're going to send somebody for debulking surgery and it's just going to grow right back very rapidly, and you sort of incur all the morbidity of the surgery and no benefit. Systemic therapy is a possibility these days. We used to think these patients were just completely untreatable, but we can treat these days if there's a targetable mutation, which is why the genetic testing upfront is so quickly. And many of these patients are going to require tracheostomy, but they may not if they've got a targetable mutation, because sometimes there's very rapid response to those therapies. So this is from the current ATA anaplastic guidelines. All anaplastic cancers are stage 4, all are associated with high mortality. But the key thing is all your imaging is going to determine whether this is something that's resectable. The genetic testing, the BRAF testing, is going to tell you whether there's something targetable. And sometimes these patients who do not initially have resectable disease can have shrinking of the tumor with the targeted therapy, and can actually make this into something that is resectable, even if it wasn't upfront. So that's why the genetic testing is important, and that's why it's important to do it really fast. Question 17, we've got a 47-year-old woman who had body mass index of 38. She's been struggling to lose weight. She's otherwise healthy, and her primary provider has recommended starting a GLP-1 receptor agonist for weight loss. However, she's anxious about associated thyroid cancer risk and has requested specialty consultation. There's a history of hypothyroidism in her maternal grandmother. Her primary care provider ordered a neck ultrasound, which showed a 0.7 centimeter spongiform nodule in the mid-left thyroid lobe and no concerning adenopathy. On her exam, her thyroid is normal to palpation. Her serum TSH is 3.42. Which is the best advice for this patient regarding thyroid monitoring while on GLP-1 agonist receptor therapy? Receptor agonist therapy. Is it that this therapy is contraindicated? She shouldn't get it. Should we measure serum calcitonin at baseline and annually, and then do thyroid ultrasound annually? Do we want a baseline calcitonin, but with no need to repeat if it's normal at baseline, but annual ultrasound, just annual ultrasound, or no additional thyroid testing? All right, most of you agreed with me, which is that we should not do additional testing. Probably she shouldn't have had that ultrasound done in the first place. So labeling in the US, although not in Europe, and I don't know in your part of the world what labels show, but in the US, the package labels for all the GLP-1 drugs include a warning about increased risk for C-cell hyperplasia in animal studies, and notes that the use of these drugs is contraindicated in patients with a personal or family history of medullary thyroid cancer or in those with MEN2. However, no guideline anywhere is recommending routinely screening for thyroid nodules before or during treatment. If we do that, we're going to be contributing to thyroid cancer overdiagnosis. We already have a huge problem with that globally. There's no evidence for benefit of serum calcitonin assessment. No guideline recommends that right now. Upcoming revised ATA thyroid nodule guidelines are going to explicitly recommend against serum calcitonin assessment or thyroid nodule screening in these patients on these GLP-1 drugs. We do not need to consider the GLP-1 use in risk stratifying thyroid nodules. We can use the same ultrasound criteria that we would in somebody not treated with these drugs. And we shouldn't restrict use of these drugs because they are obviously hugely useful and beneficial in many patients. So this is that warning label that is on the packaging in the US. It's very hard to demonstrate that a very rare result doesn't exist. So I don't know that we're ever going to get the medullary thyroid cancer warning off the US packaging, but I would note that basic and translational studies strongly suggest that this is a very specific effect that's seen in rodent thyroids with C-cell hyperplasia and medullary thyroid cancer. This does not really seem to translate into risk in humans. Randomized trials that have been done are really too small to see this rare outcome. Observational studies probably are hugely biased because of more surveillance, more ultrasounds in patients getting these drugs. But I would argue that there probably isn't a real risk, and this is probably not something that should prompt concern. And briefly, our last case is a 43-year-old. She comes for follow-up of Graves' disease. Hyperthyroidism was diagnosed 4 months ago. She's taking methimazole 10 milligrams a day. She reports diplopia, tearing, eye pain, worsening vision loss in her right eye. On exam, she has bilateral conjunctival erythema and periorbital edema. Her Hertel measurements show 24 millimeters of proptosis on the right and 21 on the left. Extraocular muscle testing shows a restricted upward and lateral left gaze. An afferent pupillary defect is present on the right. Visual acuity is 20/40 on the left and only 20/400 on the right. Her serum TSH is 1.4. Her TSI is strongly positive. Her free T4 is normal. She gets a dose of methylprednisolone without improvement. What do we do next? Orbital radiotherapy, rituximab, teprotumumab, orbital decompression, or strabismus surgery. And you're sort of split between teprotumumab and orbital decompression. I would argue that the answer here is orbital decompression because this patient is at imminent risk for permanent vision loss. So to recognize that the afferent pupillary defect and the dramatic drop in her vision on the right are emergent, she needs emergent decompressive surgery. Teprotumumab is hugely effective in active, and actually now we know even in sort of quiescent Graves' eye disease, but it doesn't work immediately, and she needs an immediate fix or she may go blind in her right eye. So she probably will need strabismus surgery down the road, but you don't want to do that while the Graves' disease is active, and that's not going to reduce her risk of vision loss. Rituximab has sort of variable results in randomized trials, but it's not going to work fast enough. And orbital radiotherapy, we don't use that so much these days since we've got better options, but again, it wouldn't be fast enough for sight-threatening disease. And with that, I think I've left us some time for questions.
Prof. Elizabeth, nice presentation. The first question is, in a female who is seeking pregnancy and diagnosed with Graves, what's the indication of stopping carbamazole in those patients during their pregnancy?
So in patients who are on antithyroid drug at the time that they become pregnant and they have Graves' disease, you can consider stopping the antithyroid drug as soon as that pregnancy is confirmed. But this is not the right solution for everybody. So if they are not well controlled on a low dose of antithyroid drug, if they have a huge goiter, if they have a very high TRAb titer, these are people who are not in remission, who may get worse very quickly if you stop the antithyroid drug, and that confers risk for the pregnancy. But consider doing this in patients where you effectively think they're already in remission, but still on a low dose of antithyroid drug. And when we do this, we monitor closely. The hope is that even if the Graves comes back, we can get them past the period of organogenesis and not have to restart till the second trimester where we're not worried about incurring birth defects.
Second question, in pregnant female without prior diagnosis of hypothyroid, but positive TPO, should we target TSH of less than 2.5 in the first trimester?
No. So in somebody who's TPO, if I'm hearing this right, I'm hearing somebody who's euthyroid but TPO positive in the first trimester. Do we need to start them on levothyroxine if that TSH is in the range of like 2.5 to 4, 2.5 to 5?
Yeah.
The answer for that is no. We said that you could consider that in the prior guideline, but there's actually no evidence for that. And we have sort of growing evidence that TPO antibody positivity confers a risk for becoming hypothyroid. So again, these are patients you want to watch thyroid function in and start if the TSH really rises to above normal. But there's no evidence of benefit for treating them when the TSH is kind of in the high normal range, even when the TPO antibody is around.
I would like to treat PTC that is found in stroma ovari in intact normal thyroid gland in ultrasound.
So weird and interesting case. You can have thyroid cancers that show up in stroma ovarii. I personally have never seen one, but I think the first thing is always just thinking about stroma ovarii, recognizing that they can be carcinogenic. The treatment on either, whether they're malignant or not, is going to be surgery to resect them. So that would be sort of the first step. And after that, you can kind of stage them the way you normally would, with the exception that if you want to treat with radioactive iodine, you also have to remove the thyroid, even if there's no tumor there, because otherwise they can't get the radioactive iodine treatment.
For patient planning for IVF, are there any guidelines or acceptable range of TSH when undergoing IVF?
So the recommendation for somebody who's not on therapy for hypothyroidism is you can just be in the normal non-pregnancy reference range, and that's, in most assays up to 5 or 5.5. So there is no benefit of lowering the TSH preconception, to the low end of the normal range. I would say, though, in somebody who is on levothyroxine already, where you can sort of control the TSH, in patients who are going to get IVF or going to conceive naturally, we do have some evidence from a huge Chinese prospective study that in probably preconception, the really optimal range is the lower half of the reference range, and ideally below 2.5. But again, that is not an indication to treat if somebody's not on therapy already. Just if they're being treated, I'd be on the safe side and keep the TSH at the lower end of normal.
Okay. In general, there's a question: the indication for radiofrequency ablation in patients with thyroid nodule.
So indications for radiofrequency ablation, this is rapidly evolving, right? This is certainly in my part of the world, this is a very new thing. So it can be used in patients with nodules that are causing compression who don't want to undergo surgery. It is effective for reducing nodule volume. It doesn't require general anesthesia, doesn't cause a scar. So there's some advantages to this. It can be used in nodules that are toxic as well as nodules that are non-toxic, like the case I showed you before. It's actually quite effective for toxic nodules. It's being used in some centers, even for very low risk thyroid cancers or metastatic lymph nodes. So I think there's sort of a growing list of indication. The one caveat is that we don't have really long-term follow-up in any of these patients today because it's a relatively new technology, and also that it's not available everywhere yet, although I think it's becoming more available as time goes by.
Levothyroxine for a patient with BMI above 30, subclinical hypo.
And I'm sorry, I'm just having a sound issue. Can you repeat?
Okay. In subclinical hypothyroid, would you start thyroxine in a patient with BMI above 30, obese patient?
Would I routinely start levothyroxine for somebody who's subclinically hypothyroid and has a BMI in the obesity range? No, I wouldn't. Important to note that there's probably a bidirectional relationship between obesity and thyroid. There's some interplay between TSH and leptin. And if you look at people who have sort of bariatric surgery or massive weight loss just from lifestyle, typically the TSH comes down a little bit with the weight loss. So some of it is hard to know what's chicken and what's egg because to some extent, hypothyroidism can drive weight gain, but also the higher weight can drive a higher TSH. So I would sort of use the same indications for treatment of subclinical hypothyroidism that I would outside that setting. I think it's really important to set expectations appropriately in patients, and unequivocally, somebody with very mild hypothyroidism, if you start levothyroxine, we all know you do not see massive weight loss. The patients all hope that's the case, but it really isn't. And in studies where they've looked at what happens to different body tissues after patients who are overtly hypothyroid are started on levothyroxine, basically what people lose is water weight. They don't lose fat mass, they diurese. So you're not going to get a major effect on weight, even though people often hope that you will. It's not wrong to treat, but if you're treating it, treat for symptoms, treat for TPO antibody positivity where you're concerned about progression to overt hypothyroidism, but probably don't treat just for the weight.
Is that centimeter of PTC patient refuse to do surgery? For how long? Or is it like lifelong follow-up? And how about if this from 1 to 2 centimeters? Does it change the practice?
Great question, and I don't think there are great answers for that yet. So do we need to follow forever in these patients who are getting active surveillance? Right now, we don't have kind of an endpoint where you can stop. What I did not see presented at the ATA meeting last week when they talked about this was that you can stop after 10 years or 8 years or whatever it is. So if that's going to be in the guideline, I haven't seen it, but current protocols like from the Japanese Endocrine Society don't really give you an endpoint. I think that's sort of an argument for not doing this right now in very young people. I don't want to follow the 30-year patient, the 30-year-old patient for 50 years with frequent ultrasounds. And it's I think another reason to sort of consider this more strongly in individuals who are older who you may not be following forever and ever and ever.
Next question, I think, from Dr. Ahmed Hassoun. He can start. Yes, Dr. Ahmed.
Yes, hi. Thank you very much. Excellent, questions and interaction. Thank you both. Question about the case of radiofrequency you mentioned about the toxic nodule. In my knowledge about this, that people have to exclude, cancer or malignancy before doing anything. I know the risk in this is not very high for malignancy, but I think the people who does radiofrequency, usually they have to do a biopsy and exclude malignancy before jumping into radiofrequency. I would like your comment. And if I might ask another question quickly, regarding by the way, I'm talking with you from Dubai. Good always to have you. The case of this elderly people who have a high TSH, you expected to be. If you have somebody who is like TSH was 12 and he started treatment, does that mean you are going to keep the TSH target is higher, like 7 or 6, not the usual normal range?
Two very good questions. And two questions for which I'm not sure there's really a data-derived answer. So typically in people with non-toxic nodules who are going to undergo radiofrequency ablation, because of the concern that you don't want to miss a diagnosis of malignancy, most centers require not just one, but 2 negative biopsies before they have the radiofrequency ablation technique. You could argue that that might not be needed because we know toxic nodules, are just generally not malignant. That's not how malignancies behave. And, for most of us in clinical practice, we wouldn't biopsy that at all. But I think requirements in different centers and different strategies have differed for this. And I think this may sort of depend on the comfort level of whoever's doing the radiofrequency ablation. So I think it would actually probably be reasonable to proceed without doing biopsy, but I think some centers may still require at least 1 biopsy of those patients to be just unequivocally sure it's not malignancy before they do the ablation. With regard to patients who are older individuals who do have subclinical hypothyroidism in a range that you treat, as you said, baseline TSH is above 10, there's a reason to treat them. Or even somebody who's overtly hypothyroid where we're treating and they're older in their 80s, do we target a different TSH range? We don't know the answer to that. It's a great question. It seems logical, right? If you know there's a physiologic increase in TSH as people age, do we treat them sort of toward an age relevant target or not? We don't have any guidance for that. The ATA is currently starting a revision for the ATA hypothyroidism guidelines. So that's not one of the 4 that's coming out next year, but that will be out in a couple of years. And I think that's one of the questions they're planning to look at. What I do in my own practice is I don't have, a specific threshold, and I probably don't feel hugely comfortable with the TSH up to 7, although I know the data suggests that I should, but I probably might treat, somebody who's older to a TSH just kind of in the upper end of the normal range. I'm not really trying to target the low end of the normal range that I would in somebody who's, young and trying to get pregnant, for example.
Great, thank you.
Okay, thanks. In question number 8, which is a patient with 3 centimeter PTC, one question here is that there is like few lymph nodes or more than 5 lymph nodes. Does this make or change the staging as well as the management?
It does change the staging. So both the size of the lymph nodes matter, whether it's sort of macro or, clinically apparent metastasis rather than just one of these micrometastases that I think is what I gave you in the case I provided. And the absolute number matters. It doesn't actually matter that much in terms of risk for mortality, but it does upstage you a little bit in the ATA post-surgery risk stratification system. And again, that risk stratification system is about to change. It was presented last week. It's not out yet. In the next year, we'll have that. And instead of 3 tiers, low, intermediate, high, we're going to have kind of low, intermediate, high, intermediate, and high. So they're going to break this down and make it a little bit more granular. And I think, I'm not quite sure what they're going to do with the lymph nodes, exactly how that's going to up or down stage you. But I think hopefully the new guidelines will be helpful in all these patients with these intermediate risk where we're trying to decide on radioactive iodine or not.
Question: do you treat women with subclinical hypo TSH less than 10 with positive antibody who want to get pregnant?
I do. And I mean, you don't have to. It's not an absolute. But in somebody where the TSH is in that 5 to 10 range, they're subclinically hypothyroid, they're TPO positive, and they're going to get pregnant. What I know, and what we have actually new data to sort of make a compelling case for, is these are women at high risk for becoming pregnant or becoming hypothyroidism once they're pregnant or as pregnancy progresses. So these are thyroids that have some sort of inability to compensate for the demands of pregnancy. And I don't want these patients to become hypothyroid when they're pregnant. I would rather intervene before. So unlike the 81-year-old patient with no symptoms, where I'm going to be kind of reluctant to start thyroid hormone for mild hypothyroidism, I'm going to be much more aggressive about it. And somebody who's planning a pregnancy might become pregnant because there, I know the pregnancy itself is going to be an additional stimulus to become hypothyroid.
And we would like to thank all the audience. And now we move to the pituitary session with Dr. Khalid Dahmani.
Dr. Naji, can I ask a question quickly?
In a few seconds.
Yeah, a few seconds.
Yes.
Elizabeth, regarding the measuring the free T4, does it really make a difference? Because the lab told me that it makes difference if the patient took the medication in the morning or he did not took for the free T4 level. It's confusing to me because usually we do it without, fasting.
I always tell my patients to take their thyroid hormone the way they normally take the thyroid hormone. I really don't worry about timing regarding testing. I don't think it makes an enormous difference. It's a hormone with an 8-day half-life, so it's not going to shift that fast.
Thank you. Thank you.
Thanks, Prof. Elizabeth, and see you hopefully in new or next meeting. Dr. Khalid, the floor is yours.
I will be replacing Dr. Khalid, so we'll go to the pituitary disorder, and inshallah we'll finish in time. It is a great pleasure for me to present to you Professor Nikki Karafitaki. I hope I pronounced the name correctly. And she is a professor of medicine and endocrinology at the Institute of Metabolism and System Research at Birmingham University, and also at the Center of Endocrinology and Diabetes and Metabolism at the Department of Endocrinology, Queen Elizabeth Hospital, University Hospital at Birmingham, NHS Foundation Trust. And if Professor Nikki, she already joined us. So without further ado, Professor Nikki Karafitaki, please start your session. And we have big group actually with us, and most of them are fellows, and also we have consultant endocrinologists, so multidisciplinary, multi-collection from the Gulf area. And so I welcome you to the stage for the session, and I am replacing actually my colleague Dr. Khalid Al-Dahmani, who is our expert actually. He is the leading the team here in pituitary. And so please, and my name is actually guest again. This is my second session. My name is Ali Al-Ma'mari, and I work at Sultan Qaboos University in Oman, Muscat.
Thank you very much, Dr. Al-Ma'mari, for the kind introduction and the invitation. Let me start sharing slides first. So
yes, go ahead, please.
Yes,
I hope things working. It was working all the time. Technically, we were successful actually, and that is good actually for our team, actually for the choice team. Thank you very much for them.
Thank you very much. So again, many thanks for the kind invitation. It's a beautiful course. I mean, I attended a little bit of it, and we never stop learning. And I think it's a fantastic initiative for all of us, not only the attendees, but also the faculty. So I have been asked to deliver a task which is very enjoyable, but I would say it's quite broad. So cover pituitary disorders. And my thought was to prepare questions which will be actually statements which will give food for thought and discussion. And these statements could be false or correct. And that's how my presentation will evolve during the next hour. So essentially, it would be a journey to the magic, to the beautiful, to the magnificent for me world of pituitary. And obviously, I have to mention that given the limits of time, we will not be able to cover everything, but hopefully the most important. So I will start with question number 1. And I will start with
Professor Nikki, could you just come near the microphone so people can hear you better? Yes, please.
Can you hear me better now? Is it better?
It's better, yes.
Yeah, thank you. Sorry about that. So let's start with the management of prolactinomas. And I would like our audience to think which statement is correct. Number 1, the greatest decreases in adenoma size and prolactin levels occur within 2 months of therapy of dopamine agonist, obviously initiation. Number 2, reduction in the tumor size may be evident within the first 48 hours with improvement of visual fields. Number 3, female sex, young age, and invasiveness, tumor invasiveness, are associated with increased risk of dopamine agonist resistance. Number 4, partial resection of a prolactinoma which is resistant to dopamine agonist cannot improve hormonal control with a lower dose of dopamine agonist. And finally, if cerebrospinal fluid rhinorrhea is suspected after initiation of dopamine agonist treatment, operative repair is urgently required. So these are the statements. I appreciate you may need a little bit of more time to think, and I'm happy to work with the needs of our audience in terms of time. So let's keep the poll. What we can see is that most of our audience have suggested that the greatest decreases in adenoma size and prolactin levels occur within 2 months of therapy initiation. And the second most popular answer is that the CSF, if there is CSF rhinorrhea, operative repair is urgently required. So let's have a look. I'm closing the poll. Let's, have a look at the answers. Okay. The correct statement is that reduction in the tumor size may be evident within the first 48 hours with improvement of visual fields. And indeed, we experience this in clinical practice. We start dopamine agonists, and within a few days, we can see improvement or sometimes impressive improvement in the visual fields. If we go to the other statements, let's see what the correct answers are. First of all, the greatest decreases in adenoma size and prolactin occur within actually 6 months of therapy initiation. Obviously, an ideal scenario would be 2 months, but it is better to wait for 6 months before we make any further decisions about the management of this tumor. In terms of factors that are associated with increased risk of dopamine agonist resistance, it's not female sex. Male sex is a factor that is considered to be a risk factor for dopamine agonist resistance, along with young age and invasiveness. Then something that we already know with publications is that if we partially resect the prolactinoma, which was not responding to dopamine agonist, this can indeed improve hormonal control with a lower dose of dopamine agonist. And this is something that we can apply in clinical practice if we come across such a scenario. And with regards to the CSF rhinorrhea, yes, management is required, but it is not necessarily an urgent action. And because I was expecting that I would have from a lot of you the answer that it is urgent, just to remind you about the CSF rhinorrhea, yes, it can rarely occur in patients with invasive macroprolactinoma, which is reducing in size with the dopamine agonist therapy. And of course, in such a case, we have to check for B2 transferrin in the nasal fluid. And if confirmed, surgical repair is required. And this is a strong statement from the consensus we have available published. But if it is mild, if it is modest, we can even consider dose of the dopamine agonist reduction and observation and see how things go. Although admittedly, in a number of cases, operative repair may be required in most of the patients. But in modest cases, it is not necessarily the action that we send directly the patient to theater. So that's about the first question. Now, let's move on to my second question, my second list of statements. And again, we move now to prolactinomas and pregnancy. And the question is, which statement is correct? Number one, pregnant women with microprolactinoma should be seen monthly during pregnancy to assess for manifestations of tumor growth. And they should have visual field evaluations at 3 monthly intervals. Statement number two, symptomatic enlargement of microprolactinomas is reported to occur in 2.4% of the patients. Statement number three, symptomatic enlargement of macroprolactinomas not previously treated surgically or by radiotherapy is reported to occur in 40% of the patients. And fourth statement, symptomatic enlargement, please bear in mind the word symptomatic. Symptomatic enlargement is reported in 20% of cases in which macroadenomas were previously treated with surgery or radiotherapy. And finally, in cases with suspicion of clinically relevant prolactinoma growth during pregnancy, an MRI with gadolinium is indicated. So let's have a look at the answers. Very interesting. So the most popular seems to be the last statement. So in cases with suspicion of clinically relevant prolactinoma growth during pregnancy, an MRI with gadolinium is indicated. And then this is followed by pregnant women with microprolactinoma should be seen monthly during pregnancy to assess for manifestations of tumor growth, and they should have visual field evaluations at 3 monthly intervals. Well, let's have a look at the correct answer, which is, trying to move. The correct answer is B, which is symptomatic enlargement in microprolactinoma, so small prolactinomas, is reported to occur in 2.4% of the patients. And this percentage gives us the confidence to stop the dopamine agonist treatment as soon as the lady with a microprolactinoma finds out that she's pregnant. And let's go to the other statements, which I think deserve a little bit of more discussion. In the first one, we had mentioned that pregnant women with micro, not macro, microprolactinoma should be seen monthly during pregnancy to assess for manifestations of tumor growth, and they should have visual field evaluations at 3 monthly intervals. Well, based on the recent consensus that we have published, this statement applies for macroprolactinomas, large tumors. And actually for microprolactinomas, there is even discussion not to really bother and follow up the patient for the risk of tumor growth, or, in my opinion, is to see these patients at 3 monthly intervals, just assess them clinically, make sure that they are okay, and don't do anything further. In terms of the third statement, symptomatic enlargement of macroprolactinomas not previously treated by surgery or by radiotherapy. In my statement, I mentioned 40%. Well, it's not so generous. It is reported in around 21% of the patients. Still, this is a number that makes us think that in large macroprolactinomas, it is better in women, which of course are rare. It is better to offer them treatment, or if they don't respond to dopamine agonists, to treat them surgically, and then mention to our patient that it is okay to go ahead with pregnancy. Of course, in this scenario, we know that there is a possibility that following surgery, the patient has hypogonadotrophic hypogonadism, and obviously pregnancy can be achieved through IVF. The other statement in terms of symptomatic enlargement is reported in 4.7%. Again, that's a different range, a different rate of cases in which macroadenomas were previously treated with surgery or radiotherapy. So this is a continuum of the previous statement. So in a woman who has a large prolactinoma, if we offer surgery, we reduce the probability that this tumor will show symptomatic enlargement during pregnancy. And the last statement, which was chosen by a significant number of our attendees, the magic word is gadolinium. During pregnancy, we would not request an MRI with gadolinium. We would go with an MRI without gadolinium. Now, another question, and probably this is the last question on prolactinomas in pregnancy, but I think it's a really interesting topic which we come across during our daily pituitary practice. So which statement is correct? Serum prolactin levels increase gradually, reaching about 20 times the values of the pre-pregnant values at the end of the 3rd trimester. Another statement, involution of the prolactinoma after pregnancy has been reported in 5% of the cases. Third statement, breastfeeding in women with prolactinoma is contraindicated. Fourth statement, if a macroprolactinoma is not shrinking and the tumor is abutting the optic chiasm, dopamine agonist treatment may be continued during pregnancy. And last statement, first-line treatment in symptomatic prolactinoma enlargement is to restart a dopamine agonist, which, however, is effective in only a few cases. So let's have a look at your answers. Right, so majority of our attendees have opted for D, and a smaller number for A, which tells us how high prolactin goes at the last trimester of pregnancy. So I'm closing the poll, and let's see what is the correct answer, which is indeed statement D. So if we have a lady with a macroprolactinoma, which is not shrinking, and the tumor is abutting the chiasm, and it happens that she becomes pregnant, and we come across such scenarios, rarely, but we do come across. So dopamine agonist treatment may be continued during pregnancy because we know that there is a risk of further enlargement of the prolactinoma, and also the normal lactotrophs will also increase in size, and the combination of these could pose threats to the vision of our patient. Let's have a look at the other statements. In terms of serum prolactin levels, they reach around 10 times the values of the pre-pregnant values at the end of the third trimester, not higher. And of course, as we all know, we should not measure prolactin during pregnancy, even in a patient with a prolactinoma. In terms of evolution of prolactinoma during pregnancy, this has been reported in various series between 17 and 68% of the cases. And that's an interesting scenario, because if our lady delivers, when she delivers, and if she decides to breastfeed, and then later we want to see if it is worth restarting the dopamine agonist, we come across cases in which the hyperprolactinemia has resolved. So indeed, pregnancy is one of the scenarios that prolactinomas, especially the very small ones, may involute. So we keep this in mind. Breastfeeding in women with prolactinoma is not contraindicated. If a lady wishes to breastfeed, we will not say no, but we have to be careful in the scenario in which the patient had a large pituitary tumor, and in such a case, not delaying restarting the treatment, delaying to restart the treatment may pose risks for the behavior of the prolactinoma. We wouldn't, this is the scenario in which we wouldn't like to leave our patient without treatment. And statement D, as we mentioned, is the correct one. And if we have symptomatic prolactinoma enlargement, we can restart the dopamine agonist, and indeed, it has proven to be effective in most of the cases, not in a few cases. So thankfully, we rarely come across the case where urgent surgery, for example, may be needed for the patient, or urgent delivery. Now, question number 4. This is a topic that is discussed a lot, and probably there is still a lot of discussion on that. And it has to do with the screening for valvular disease in patients with prolactinoma who are on dopamine agonists. So let's see which statement is most likely to be correct. A, valvular disease screening is not needed in patients with prolactinoma. B, referral to cardiology is needed to all patients before starting dopamine agonists. Statement C, we need to arrange an echocardiogram every 5 years in patients treated with more than 2 milligrams cabergoline per week. Statement D, we need to arrange an echocardiogram every 2 to 3 years in patients who are treated with more than 4 milligrams cabergoline per week. And statement E, we need to arrange an echo every 2 to 3 years in patients who are treated with cabergoline at a dose of more than 2 milligrams per week. It's a game of numbers, I guess, here. So let's have a look at your answers and your thoughts and your practice. Okay, interesting. Again, there is there are answers which are similar, I understand, and what dominates is that arrange echocardiogram every 2 to 3 years in patients treated with more than 2 milligrams cabergoline per week. But we do have answers in which we arrange an echo every 2 to 3 years in patients treated with more than 4 milligrams per week. I would like to emphasize, I use the word most likely to be correct, simply because there is a lot of discussion on what we should really do with the echocardiogram in these patients. So based on guidelines, and I will show them to you in a slide in a minute, we would arrange echo every 2 to 3 years in patients treated with more than 2 milligrams cabergoline per week. This is the dose that we use as a cutoff. And indeed, these are the guidelines which were jointly developed by the British Society of Echocardiography, the British Heart Valve Society, and the Society for Endocrinology in the UK. And just some points to remind to you. And before that, please bear in mind that all these statements are weak. They don't have enough evidence. And that's why I mentioned which statement is most likely to be correct. So to summarize, if long-term treatment with a high dose, and this is more than 2 milligrams per week of cabergoline, is anticipated, it is advised to perform a baseline echo to detect any pre-existing valve alterations. And baseline evaluation can be performed before starting cabergoline therapy or during the first 2 months of treatment. So we don't necessarily need to rush and be anxious and organize an echo at time 0 when we start cabergoline. And in patients who are treated with more than 2 milligrams per week of cabergoline, repeat the echo every 2 to 3 years. In the consensus that we had, most of the participants thought that annual cardiac examination is not necessary. If we go with a lower dose of cabergoline, equal or below 2 milligrams per week, perform echo every 5 to 6 years. And some of the participants, some of the colleagues believed that these repeat examinations were not really necessary in patients treated with less than 1 milligram per week and who had, of course, no clinical signs or valvular dysfunction. And another thought is that if we detect a heart murmur in patients who are treated with cabergoline, this should prompt echocardiography. And as I mentioned, these are guidelines and weak statements, so I appreciate that clinical practice may vary. Question number 5, the other topic, dopamine agonist treatment withdrawal. So which statement is correct? First, favorable predictors of successful withdrawal include low maintenance doses of cabergoline, treatment duration more than 2 years, and substantial adenoma size reduction. Second statement, the risk of recurrent hyperprolactinemia after dopamine agonist withdrawal is 26 to 69%, and recurrences are most likely to occur within 1 month. Third statement, patients with long-term normalized serum levels of prolactin after cabergoline re-challenge. So these patients were stopped the treatment, the prolactin increased, they went back to the cabergoline and they had normal prolactin. So in this group, we should not attempt another withdrawal trial. And finally, after withdrawal of dopamine agonist treatment after menopause, prolactin remains normal in 10% of the cases. So let's have a look at the answers. So majority have opted for answer A, and a very small number of colleagues have opted for the other statements. So let's have a look. Let's have a look which is correct. Correct is indeed statement A. So if we want to consider withdrawing the dopamine agonist, we need to be sure that our patient is on low maintenance dose of cabergoline, and sometimes we gradually reduce the dose and we see that prolactin remains normal, and then we attempt withdrawal of this treatment. Literature mentions treatment duration more than 2 years, and yes, substantial adenoma reduction. The word substantial is questionable. What do we mean by that? And some colleagues may even consider disappearance, at least on imaging, of the tumor. And in terms of the other statements, for B, the risk of recurrent hyperprolactinemia after dopamine agonist withdrawal is indeed quite broad, and these are the percentages we have in the literature, but the recurrences most likely occur within 1 year, not necessarily a majority of them within 1 month. So obviously we need to continue monitoring the patient after the month, no doubt about that. Now, the statement C introduces another aspect in the management of patients who had withdrawal of a dopamine agonist. And there is indeed literature which suggests that if we attempt withdrawal of a dopamine agonist and it's not successful, this doesn't mean that we have necessarily lost the battle. We can continue for 1 or 2 years on the same treatment and then reconsider and think whether we can attempt another withdrawal. And yes, the chances that this is successful are not very high, but there are indeed cases that this worked. And the final statement, if we stop dopamine agonist treatment after menopause, the prolactin remains normal in more than 50% of the cases. We and others have published on that. And actually, this gives a stimuli, food for thought as to how we manage women who have a prolactinoma treated with dopamine agonist and they reached a menopause. And this is particularly relevant for women with microprolactinomas. And we know that prolactin may remain normal if we stop treatment, or it may go up. And we do have women who reached menopause, they had a micro, we stopped treatment, prolactin went up, then it stopped after a while, going further, and we simply monitor them with prolactin measurement. So this is an option that could be applied in clinical practice. Now, question number 6, I would like to move to another exciting for me entity, and I'm sure for you as well, the functioning gonadotroph adenomas. These are, as we all know, adenomas which express and secrete biologically active gonadotropins. So they are not the typical non-functioning gonadotroph adenomas, and they cause distinct clinical manifestations. And if we focus on these tumors in women, I would like you to think which statement is correct. Number 1, estrogen levels can fluctuate. Number 2, FSH levels are always above the reference range in these women. Number 3, the alpha subunit is always high. And number 4, LH levels are usually high. In our career, I know that we don't often, or rarely, I should say, come across with such cases, but they are indeed quite challenging and fascinating. Okay, quite interesting. So majority have opted for the alpha subunit, which is always high. And then this is followed by the FSH levels, which are always above the reference range. And also LH levels are usually high. Well, let me share what we have about these tumors. And the correct answer is that estrogen levels can fluctuate. We can have women with functioning gonadotroph adenomas, with large ovaries, as I will show you in a second, and still their estrogen levels may be within the normal range at the time that we measure them. And if we measure them later, they can be higher. So this is a table from a paper we had published in the Journal of Clinical Endocrinology and Metabolism a few years ago, in which we had summarized the manifestations, presenting manifestations, biochemical findings, and imaging findings in women, in premenopausal women with functioning gonadotrophs. And yes, they will present with menstrual irregularities, which could involve oligo or amenorrhea, spotting, menorrhagia, infertility, galactorrhea, and mass effects, and ovarian hyperstimulation syndrome. The biochemical findings, which can be quite challenging, we can have high estrogens, but occasionally they may be normal or fluctuating. Serum FSH is not necessarily above the reference range. It can be within the reference range, at least what we measure, what the lab gives us. And LH is usually suppressed or within the reference range. The alpha subunit can be elevated, but can also be normal. In terms of the pelvic imaging, we have this typical picture of large ovaries with cysts of variable size, and often these cysts are larger than 5 centimeters, in both ovaries. And actually, when we remove the tumor and we have successful treatment, the ovaries go back to where they were. Another interesting point is in postmenopausal women, in which this entity, the functioning gonadotrophadenomas, cannot be really picked up, cannot be diagnosed, because the ovaries are depleted from the preantral follicles and are insensitive to FSH stimulation. So we will not see the large ovaries, we will not see the levels of estrogens going up. So in this group, the diagnosis of a functioning gonadotrophadenomas is quite difficult, particularly also given that the gonadotrophins increase during menopause. And how about this entity in men, in males? And now I'm asking you to pick up which statement is false, is not right. So testosterone levels can be below the reference range. Testosterone levels are always high. LH levels can range from low or within the reference range or above the reference range. And cases with increased sperm count have been reported. So let's have a look at your answers. Okay, very interesting. Majority have opted for the answer B. Testosterone levels are always high in a functioning gonadotroph, and this is followed by the LH levels, which can range. Okay, so let's see what happens with this entity. Which statement is false? Testosterone levels are always high. This is false. Testosterone levels can be anything. And the other statements are correct. So testosterone can also be below the reference range in case we have true hypogonadotrophic hypogonadism. The LH levels can be anything. And yes, cases with increased sperm count have been described. And again, I'm taking you to the table of our paper in GCNM. What do we expect to see in this entity? We can see testicular enlargement, not necessarily though, but it can be there. And ideally, it would be useful to do an ultrasound of the testes to identify and confirm that. We can have hypogonadism, we can have mass effects. How about the biochemical findings? The FSH usually is elevated, or I should say in most of the cases that we come across, the LH and the testosterone are slightly below the reference range, or they can be normal, or they can be elevated. And the alpha subunit, again, can be normal or elevated. And as we mentioned, we can have cases of increased sperm count. The ultrasound of the scrotum will show the testicular enlargement. And as I mentioned, this would be an imaging modality that would be useful in this setting. Now, let's move on to another entity, one of the emergencies, and one of the few, I should say, emergencies in pituitary endocrinology, pituitary apoplexy. And the question is, which statement is correct? Okay, which is correct? Cranial nerve 4, number 4, is the most commonly affected. In the hyperacute stage, and we are talking about the first 3, 4, 5 hours, the CT brain shows a hypodense lesion. In the hyperacute stage, again, in the first few hours, the MRI shows an ISO or slightly hypointense lesion on the T1 weighted images. And in the acute stage, so we are leaving the hyperacute stage, we are going to the acute stage, which is from the first few hours until around 7 days, the MRI shows a hypointense lesion on the T1 weighted images. Let's have a look at the answers. Okay, so majority have opted for number 4, D. In the acute stage, the MRI, and I remind you again, acute stage is from the first few hours until 7 days or so. MRI shows a hypointense lesion on T1 weighted images, and this is followed by the hyperacute stage in which the MRI shows an ISO slightly hypointense. Well, let's have a look. What is the correct answer? The correct answer is indeed number C. And it's important to remember this. In the hyperacute stage, the MRI, especially in the absence of a distinct adenoma, can show an intense lesion, and we can be deceived at that time and think that we are not dealing with apoplexy. And this is because the hemorrhage may be still in the form of the deoxyhemoglobin. Or if we just have infarction and not hemorrhage, again, we may have these findings. So the first few hours, for the very first few hours, MRI can deceive us. And let's look at the other answers. The most commonly affected cranial nerve is number 3, and I'll show you a slide in a second. In the hyperacute stage, first few hours, the CT brain shows a hyperdense lesion. So CT in the very, very first few hours may be more useful than MRI. And statement D, in the acute stage, the MRI shows a hyperintense, not hypo, hyperintense lesion on the T1 weighted images, because at that stage we have a transformation to methemoglobin, and this can show the high signal. So we can see that as time passes, and hours and days, the imaging features of pituitary apoplexy evolve. And when to suspect this condition? Our patient presents with acute severe headache, and it's quite characteristic because the patients mentioned that they never had experienced something like this before, combined or not with nausea and vomiting. We may have neurophthalmic signs, which will involve the visual acuity and the visual fields, ocular palsies, and as we mentioned, the cranial nerve palsy number 3 is the one which is most commonly affected. We can have fever, neck stiffness, photophobia, reduced consciousness. Obviously, the situation is serious then. And if we have a patient who we know that has a pituitary tumor and presents with this clinical picture, our mind should immediately go to the scenario of pituitary apoplexy. Question number 9. We are still in pituitary apoplexy. Now, which statement is correct? A, during the acute presentation, stress dose of hydrocortisone is offered immediately after biochemical confirmation of ACTH deficiency. Number 2, severe visual deterioration is not an indication for surgery. Number 3, pituitary adenomas presenting with apoplexy have no risk of regrowth during follow-up. And number 4, cranial nerve 3 palsy, the one we mentioned earlier on, is not an absolute indication for surgery. So let's see your thoughts. Okay, so cranial nerve palsy is not an absolute indication for surgery. Majority of my colleagues have opted for that, followed by the stress dose of hydrocortisone when we are going to offer it. So let's see what the correct answer is. Indeed, cranial nerve 3 palsy is not an absolute indication for surgery. If we only have this palsy and we don't have deterioration of the visual fields or issues with the visual acuity, we can have the luxury of waiting when the edema is absorbed to a major extent, and we can indeed improve we can indeed wait for improvement in the clinical picture. So this is correct. With regards to the other statements, I think the first statement was a little bit tricky because we would recommend stress dose of hydrocortisone to be offered immediately. We don't have to wait for the confirmation, the biochemical confirmation of ACTH deficiency. We may lose precious time. And of course, the protocol would be, we have the suspicion for pituitary apoplexy. We immediately take blood samples, not only for the routine biochemistry, but also for hormonal assessment. Amongst them will be cortisol levels. We offer hydrocortisone, and when the result is back of the cortisol, we decide what we do next. But definitely, as an acute measure, we need to offer stress dose of hydrocortisone. And of course, yes, severe visual deterioration is an indication for surgery. And in terms of adenomas, regrowth after apoplexy, they do have a risk of regrowth. Apoplexy doesn't mean that the tumor is dead. There is always a possibility that the tumor will regrow. We had published on that a few years ago, in which we showed regrowth rates in apoplectic non-functioning pituitary adenomas, which were there, not as high as non-apoplectic, but they were there. And also, if a tumor is not managed by surgery and shows apoplexy, there is still a risk of growth in the years to come. So we need to be alert about that. Question number 10. Let's go to another challenging and beautiful topic, the hypercortisolism and the Cushing's disease. So I would like us to think from the conditions which are associated with physiologic hypercortisolism. And here I've put down 5 conditions, 5 scenarios, and I would like you to think which is wrong, which is false. Of course, yes. Relatively easy, but gives us again food for thought. Majority opted for the right answer, which is the wrong actually statement, testosterone replacement. So yes, obesity can be associated with high cortisol levels. It can cause trouble when we want to confirm the diagnosis of Cushing's. Depression, we all know about that. Alcohol dependence and physical stress, any type of physical stress. And this is why we should not perform screening or diagnostic tests for Cushing's if our patient is very unwell, because we may end up with false positive results, and this is not a good way to start with the management of these patients. Question number 11. Which is correct this time? So transdermal estrogen patches can lead to a false positive dexamethasone suppression test. High fluid intake, and we put the number of more than 5 liters per 24 hours, can lead to falsely low levels of 24-hour urine-free cortisol. Salivary cortisol samples can be stable at room temperature. 24-hour urine-free cortisol is the most accurate test to diagnose endogenous Cushing's, and carbamazepine does not have an impact on the results of the dexamethasone suppression tests. So which statement is correct amongst these 5 ones? Okay, so majority of our colleagues have opted for statement number B. High fluid intake can lead to falsely low levels of 24-hour urine-free cortisol. And the others are more or less shared apart from the last one. Let's have a look. Let's see which is the right answer. The right answer is number C. Salivary cortisol samples can be stable at room temperature. Obviously, we are not implying that these can remain at room temperature for a month. But nowadays, we have the luxury of the patients producing a salivary sample in the salivette, putting it in an envelope and posting it to us without them having to come to our department. And this is particularly important when we are taking late night salivary samples. So salivary cortisol has indeed facilitated not only the diagnosis, but also the monitoring of Cushing's. And let's have a look at the other statements, because it's worth discussing them. Transdermal estrogen patches, they do not lead to a false positive dexamethasone suppression test. Oral estrogens increase the cortisol binding globulin, and therefore we have high total cortisol levels. And when we do a dexamethasone suppression test, it will be false positive. The patches overpass the liver, and therefore they can be used in patients who are investigated for Cushing's. In terms of fluid intake, high fluid intake actually leads to falsely elevated high levels of 24-hour urine-free cortisol. This has to do with the increased free cortisol excretion, and this is very important to remember when we are asking our patients to do 24-hour urine collections for us to check the urine-free cortisol. And quite a number of patients who are really enthusiastic to do the test properly, they drink plenty and plenty and plenty of fluids, thinking that this will improve the diagnostic accuracy of the test, when in reality it causes the opposite. So we advise the patients to drink as per thirst. We discussed the salivary cortisol samples, and in terms of 24-hour urine-free cortisol, no, it is not the most accurate test to diagnose endogenous Cushing's. We know that particularly in cases of mild Cushing's, the 24-hour urine-free cortisol may be normal, and carbamazepine does have an impact on the results of the dexamethasone suppression test. We know that carbamazepine increases the clearance of dexamethasone, and this can cause problems. Now, let's go to question number 12. Again, we remain on Cushing's, and which statement is correct? First, definition of remission of Cushing's disease after surgery is by us confirming blood cortisol below 100 nanomoles per liter. Number two, factors associated with remission of Cushing's disease after transsphenoidal epidermoidectomy are size of the tumor and sphenoid sinus invasion. Number three, the recovery from the glucocorticoid withdrawal syndrome takes place within 3 months after surgery. Number four, the HPA axis recovery is usually within 6 to 12 months after surgery. And last, in persistent Cushing's disease after surgery, stereotactic radiosurgery is expected to lead in remission within 1 year. So let's see what your thoughts are. Okay, so majority have opted for the recovery of the axis within 6 to 12 months, followed by more or less similar number on the statement on the factors associated with remission after TSA. And a smaller number of colleagues have opted for the others. So let's see. Let's have a look which is the correct answer. And the correct answer is D. The recovery of the axis usually is within 6 to 12 months after surgery. It can take a bit longer. We come across cases in which it takes longer, but the rule of thumb would be within 1 year. And with regards to the other statements, nowadays, the definition of remission of the Cushing's after surgery is blood cortisol below 50, 55 nanomoles per liter. We are more strict nowadays. In terms of factors that are associated with remission after transsphenoidal surgery, yes, it is the size of the tumor, but importantly, not the sphenoid sinus invasion, but the cavernous sinus invasion. If the tumor goes down to the sphenoid, it will be easy for the surgeon to remove it. But if it goes into the cavernous sinus, and especially it is CROSP 3 or 4, we know that this tumor is not amenable for complete removal. In terms of glucocorticoid withdrawal syndrome, this can last 1 year or longer, and patients may suffer because of this. Occasionally, we may offer a little bit of a higher glucocorticoid replacement dose, but not for long, because we don't want the patients to be Cushingoid. And finally, in persistent Cushing's disease after surgery, the SRS is expected to lead in remission within 2 years. And we give this sort of rule of thumb of 2 years because this will be the time, the 2 years, that we will have to sit down and decide if SRS has provided a benefit, and if not, we may have to think of other options, management options for our patient. Question number 13. Again, Cushing's, which statement is correct? Half of the recurrences of Cushing's disease after surgery occur within the first 2 years. Early recovery of the HPA axis is a factor associated with recurrence of the Cushing's. In most patients with recurrence of the Cushing's, dexamethasone suppression test is abnormal earlier than the late-night salivary cortisol test. Medical treatment should not be used as bridge treatment after radiotherapy, and block and replace regime has no value in cyclical Cushing. So which statement is correct? Okay, let's see the answers. Majority have opted for B. Early recovery of the HbA axis is a factor associated with recurrence of the Cushing's. A significant number mentioned that half of the recurrences after surgery occur within the first 2 years. Let's see which is the most, or at least we think is the most correct. Indeed, what the majority of you have opted for is true. So early recovery of the axis is a factor which is associated with the recurrence of the Cushing. So if we have a patient with Cushing's disease and has transsphenoidal surgery, and within a month or 2 months, we see that the axis is recovering, then this can be a not good sign. We have to start waiting that this patient most likely will show recurrence. In terms of the other statements, half of the recurrences of Cushing's disease after surgery occur actually within the first 5 years. And we have to be alert for that. And not only that, I have personally seen a recurrence of Cushing's 20 years after successful transsphenoidal surgery. And obviously, we never stop monitoring these patients for that. In terms of which test is going to become abnormal first, when we are dealing with recurrence of the Cushing's, this is actually late-night salivary cortisol, and then the dexamethasone suppression test becomes abnormal. Obviously, if we pick up an abnormal late-night salivary cortisol, we are not going to rush and make a therapeutic decision for the patient. We would wait for the dexamethasone suppression test, but this would be a sign that things have started going wrong. And medical treatment, yes, it is used as bridge treatment after radiotherapy until the radiotherapy does the job. And block and replace regime, of course, has value in cyclical Cushing's. We know it is an entity which can be difficult to manage with the fluctuations of the cortisol level. So it is better to give a high dose of steroidogenesis inhibitor plus glucocorticoid and keep our patient stable. Let's go to question number 14 about Cushing's again. Which statement is false? For false, not correct, false. For rapid normalization of cortisol, adrenal steroidogenesis inhibitors are the preferred medical treatments. Number 2, bilateral adrenalectomy is a life-preserving emergency treatment in very severe Cushing's, which cannot be promptly controlled with drugs. Number 3, predictive factor of corticotroph adenoma progression, or what we used to call Nelson's after bilateral adrenalectomy, is very high ACTH in the first year after adrenalectomy. D, pituitary imaging after bilateral adrenalectomy should be performed every 3 years. And finally, excess weight, hypertension, diabetes mellitus type 2, and dyslipidemia may persist even after successful management of the Cushing's. So which statement is false? Okay, so majority of our attendees have opted for the pituitary imaging after bilateral adrenalectomy, which should be performed every 3 years. And it's interesting to note that, again, a quite significant number feel that these comorbidities may persist, may not persist after successful treatment. All right, let's have a look. Let's have a look at the false answer, which is indeed pituitary imaging after bilateral adrenalectomy should be performed every 3 years. No, there are specific protocols for that, and I'll show you a slide in a second. But let's take the journey to the other statements. So for rapid normalization of cortisol, of course, adrenal steroidogenesis inhibitors are the preferred medical treatments. And we have also used the TOMI date in cases of severe emergencies and aiming to drop the cortisol levels as soon as possible. And bilateral adrenalectomy is still an option, and a good option many times, in the treatment of very severe Cushing's, which cannot be promptly controlled with drugs. If we want to predict which corticotroph adenomas will progress after bilateral adrenalectomy, the most consistent factor that has been reported is high ACTH levels in the first year after adrenalectomy. And indeed, excess weight, hypertension, diabetes, dyslipidemia. So all these comorbidities that are associated with Cushing's may indeed persist even after successful management of Cushing's disease. And this statement highlights the importance of monitoring and managing aggressively sometimes the comorbidities that that the patient has had due to their Cushing's, even if this ends up being in remission. And with regards to the protocol, we had again published a few years ago a consensus on how we monitor the patients after bilateral adrenalectomy. So surveillance by MRI imaging and 1 to 2 millimeter slice thickness, so thin slices after 3 months, and then every 12 months for the first 3 years after the adrenalectomy. Clinical surveillance every 12 months, and then MRI imaging can change at increasing intervals every 2 to 4 years, depending, of course, on the ACTH and clinical parameters after that. But in high-risk patients, we should always consider closer surveillance because we don't know how this corticotroph tumor is going to behave. And we are leaving the Cushing's, and now we are going to one of my favorite topics, the craniopharyngiomas. So one question here, which statement is correct about craniopharyngiomas? Mutations have been identified in the adamantinomatous subtype of cranio. Papillary craniopharyngiomas are reported almost exclusively in children. Irradiation of cystic cranios carries risk of enlargement around the period of radiotherapy. Growth hormone replacement is an absolute contraindication in adults with craniopharyngioma, and a dipsic diabetes insipidus or central or vasopressin deficiency, as we're trying to call it nowadays. So a dipsic DI in patients with cranio requires large doses of desmopressin. So what are your thoughts on which statement is correct here? Okay, so majority of our colleagues feel that a dipsic DI in patients with cranio requires large doses of desmopressin. And we have a bit of a share, and only 4% mentioned that irradiation of cystic cranio carries risk of enlargement around the period of radiotherapy. And actually, the correct answer is C. We have to be very careful when we have especially a predominantly cystic craniopharyngioma. Irradiation carries a risk of enlargement, and this is something that all oncologists keep in mind, and quite often they offer dexamethasone at around that period. So that's the only statement which is correct. How about the other statements? BRAF mutations have been identified in the papillary subtype, not the adamantinomatous subtype. And nowadays we have discussion on offering BRAF inhibitors in these patients. The papillary craniopharyngiomas have actually been reported almost exclusively in adults, not in children. So the BRAF inhibitors can be offered in adults mostly. Growth hormone replacement is not an absolute contraindication in adults with craniopharyngioma. We know that we are offering replacement dose, not pharmacological doses. So the attitude would be manage the tumor, make sure the tumor is stable, and then offer growth hormone replacement if needed. And a dipsic diabetes insipidus in patients with craniopharyngioma requires the usual doses of desmopressin, like in other patients. But in these cases, we need to make sure that we offer the appropriate amount of fluids that the patient should receive. So this is a fixed amount of fluid. We need to monitor that. We need to weight the patient, and we need to do sodium measurements at regular intervals. Now let's move to Rathke's cleft cyst. This is a quite common finding on incidental finding on brain images. And I would like you to pick up which statement is correct. presence of wet keratin is a characteristic histological feature of Rathke's. On MRI, they usually appear as well-demarcated cystic lesions with homogeneous intensity signal, and sometimes this is combined or not with thin cyst wall enhancement. Majority of incidentally found Rathke's enlarged during follow-up. Intracystic irradiation is a useful management option for Rathke's, and radical removal of a Rathke's cleft cyst completely prevents relapse. So which statement is correct? Okay, majority have opted for B, and we see a smaller spread of the other answers. So let's see which statement is correct. Indeed, on MRI, they usually appear as well-demarcated cystic lesions. They have homogeneous signal intensity. It's something that we rarely miss as a diagnosis. For the other statements, let me just highlight you an important point on histology. Wet keratin is not a characteristic feature of Rathke's. Wet keratin, and please keep this in mind when you read histology reports, is characteristic of an adamantinomatous craniopharyngioma. The majority of incidentally found Rathke's, thankfully, they don't enlarge during follow-up. This is what data suggests. Intracystic irradiation has not been used for Rathke's. In Rathke's, we offer surgery. There are a few cases in which irradiation was offered, external irradiation, but it's not something that we apply nowadays, and definitely not intracystic irradiation. And even after radical removal of the Rathke's, we can see relapse of this lesion. So radical removal does not necessarily solve the problem of the patient. Question number 17. This is acromegaly. Let's move to the other entity. Which statement is false? Okay, not correct. Prevalence ranges between 3 to 14 cases per 100,000 people. The duration of active acromegaly is a factor that influences various long-term morbidities. After biochemical control of acromegaly, there is complete reversal of sleep apnea syndrome. Prevalence of arthropathy in acromegaly, based on registry studies, is 20 to 69%. It involves both weight-bearing and not weight-bearing joints. And biochemical control of acromegaly does not reverse arthropathy in these patients. So which statement is false, is not correct? So a majority have answered number C. So following biochemical control of acromegaly, there is complete reversal of the sleep apnea syndrome. We have some other answers. So indeed, this is false. This is something we need to keep in mind. We need to continue monitoring these patients for sleep apnea and obviously manage them accordingly. In terms of the other answers, acromegaly remains a rare condition, 3 to 14 cases per 100,000 people, and these are from population studies. The duration of active acromegaly does play a role for long-term morbidity. So the earliest we diagnose this condition, the better. The prevalence of arthropathy in acromegaly has a wide range, and unfortunately, biochemical control of this condition does not reverse the arthropathy. And actually, the pain these patients have and suffer from is one of the major factors that affects their quality of life. And another relatively quick question about acromegaly. Which factor does not relate with responsiveness to somatostatin analogs? Is it the expression of somatostatin receptor 2 in the tissue, the tumor, size of the tumor, lower baseline growth hormone and IGF-1 levels, granularity of adenoma, so densely or sparsely granulated, or prolactin levels? So does not relate with responsiveness to these agents. Indeed, prolactin levels, majority of you have chosen the right answer. So we know, let me just progress the slide, that expression of the type 2 receptors, somatostatin receptors, size of the tumor, lower baseline growth hormone and IGF-1 levels, and granularity of adenoma play a role. Sparsely granulated adenomas are reported to be less responsive to somatostatin analogs. Prolactin levels, we don't care. I mean, it's something that will not define our choice. And another question, which statement is false in acromegaly? False, not correct, false. Response to radiotherapy is associated with the pre-treatment IGF-1 levels. Aortic regurgitation is higher in patients with acromegaly compared with controls. Pegvisomant treatment has neutral or beneficial impact on glucose metabolism, obviously in patients with acromegaly. Surgical debulking improves the response to long-acting somatostatin analogs, and cabergoline should be used only in cases of acromegaly with prolactin co-secretion. So which statement is false, is not correct? Okay, so majority have opted for E as a false one. We have a smaller spread of other answers. So indeed, cabergoline can be used also in cases of acromegaly or in cases, as I should say, of tumors causing acromegaly, but also not necessarily co-secreting prolactin, just pure acromegaly. Mild acromegaly usually responds to cabergoline, and it's an option we could consider. For the radiotherapy, the highest the IGF-1 levels we start with, the less the chance of achieving normal IGF-1 in the years to come. Aortic regurgitation is higher in patients with acromegaly. We need to, in our center, we do that. We do an echo at baseline in all patients with acromegaly. In terms of glucose metabolism, pegvisomant seems to have a beneficial or neutral effect. And if we have a patient with a pituitary tumor causing acromegaly, if the tumor does not respond to long-acting somatostatin analogs, if we manage to debulk part of the tumor, the responsiveness will improve. We had published on that probably 15 years ago, and it is a common knowledge nowadays. And I have two more slides for my another favorite tumor, the non-functioning pituitary adenomas. Let's devote a couple of minutes on them because they cross our door quite often, I would say. So let's start with non-functioning pituitary small, okay, adenomas. Which statement is correct? In radiological series, 42% of healthy people with no previous known history of pituitary disease have pituitary abnormalities on MRI. Cumulative probability of tumor growth is around 8% at 3 years follow-up, or it is 40% at 5 years follow-up. Cumulative probability of tumor shrinkage is around 3% at 3 years follow-up, and repeat assessment of the pituitary function is indicated at yearly intervals. So we are focusing on non-functioning pituitary microadenomas. Which statement is correct? Right, okay. So D and E followed with equal numbers, A and B. Let's see which is the correct answer. Correct answer is that cumulative probability of tumor growth is around 8% at 3 years follow-up. And this comes from a study we published from the UK NFPA consortium, published in the European Journal of Endocrinology last year, in which we clearly showed that the probability of growth is very small in these tumors, at 3 years, 8%, and therefore the proposal nowadays is not to rescan these patients within a year, as we used to do. And for the other statements, in radiological series, yes, 10 to 38% of healthy people may have a pituitary abnormality on MRI, not necessarily an NFPA, but we can imagine that these numbers are alarming, and you can think of the burden to the healthcare system. And from the same study, the UK NFPA consortium, we found that the cumulative probability of growth is only 15% at 5 years follow-up. And a small number of these tumors may also shrink, 14% at 3 years. So this is something that can happen. With regards to the repeat assessment of the pituitary function, again, the consortium showed that in microadenomas, there is no point repeating the pituitary function every year. Of course, the exception can be if there is clinical indication, if we have clinical suspicion that things have changed. And my last question, in non-functioning pituitary, I apologize for the typing error. It is macroadenomas, not micro, macro, above 1 centimeter. Which statement is correct? Disconnection hyperprolactinemia rarely reaches levels above 3,000 milliunits per liter. Null cell adenomas do not express transcription factors or pituitary hormones. Extent of residual adenoma following surgery is associated with NFPA regrowth. NFPAs do not require imaging surveillance after 10 years of stability of imaging, and radiotherapy reduces the risk of NFPA growth after surgery. So please pick up which statement is wrong. And we are talking about macroadenomas, not micro. So most of you think that this what is wrong is disconnection hyperprolactinemia rarely reaches levels above 3,000 milliunits per liter. You think that this is wrong. Let me show you the correct, which is false. All the other statements are correct. False is that NFPAs do not require imaging surveillance after 10 years of stability on imaging. No, that's wrong. We never stop imaging these tumors because they can still show regrowth. All the other statements are correct. And particularly the extent of residual adenoma following surgery can be a predictor of NFPA regrowth in the years to come. And radiotherapy, it does reduce the risk of NFPA regrowth after surgery. Disconnection hyperprolactinemia rarely reaches levels above 3,000 milliunits per liter, but of course, we need to know what is our assay and how it picks up macroprolactin. And with this, I would like to thank you very much for your attention and for your participation. It has been an exciting experience for me looking at your answers and how you think and your practice. Thank you very much.
Thank you very much, Prof. Nikki. It wasn't easy question. I could tell from the answer. It was spread all over, but it was very useful. Now we go to the question. Just give me 1 minute, please. So I'll start from the beginning. Okay. This is for Professor Young. Okay. I just trying.
Ali, if I might ask a question, Ali, while you're waiting.
Yes, please. You go, Dr. Ahmed Hassoun. I'm trying to get.
Yeah, it's okay. Thank you very much. Really, as Dr. Ali mentioned, it's a really interesting and very, educative questions. I'm Ahmed Hassoun from Dubai. Question for you is really clinical one from about acromegaly and growth hormone. If you have somebody who have non-functional adenoma or incidentilloma, you find because it's not incidentoma, actually. Somebody have a mild hyperprolactinemia, a young lady, and you investigated her because of that. You're thinking of a stock effect, and you do the MRI, and you find a small microadenoma there. You start working into this microadenoma to see if it is functioning or not functioning, right? And when you do the investigation, you found IGF-1 is high. And then you do the suppression for growth hormone. You say it's not suppressed. Patient is a young lady without any symptoms of acromegaly, with a very small, adenoma. I would call it about 5 millimeter, which in a way, if it's really confirmed, this is a very lucky lady that it is diagnosed early. I would like your opinion in approaching this case.
Yes, thank you very much, Dr. Hassoun. That's a very challenging question, I would say, because we do come across such cases as well in our department, and we still discuss what is right or wrong. First of all, my practice is to repeat the IGF-1, okay, and make sure that this is indeed elevated. We know that the problems with the IGF-1 assays and how tricky they can be. Personally, sometimes I even send a sample to another lab with a different assay and see if the IGF-1 is confirmed to be high. If we finally end up with a high-ish IGF-1 and no suppression on the OGTT, I will take a very careful history of the patient. Particularly, I will look at previous photos 10 years ago and see if the patient develops clinical features of acromegaly. If this is the case, then I will discuss with my patient the option of surgery, mentioning that we want to lead what seems to be acromegaly in remission, because if she's young and she or he exposed to many years to growth hormone excess, this can have an impact not only on her long-term survival, but a number of comorbidities. Obviously, we will inform her of the side effects of surgery, the risks that are associated, and then we make a decision with the patient. The other scenario would be not to do anything invasive and mention to the patient, let's wait, maybe the acromegaly will become more serious biochemically as time passes, and this will give us a higher and more argument for an operation. So to cut the long story short, this is something that needs to be discussed with the patient. My personal approach is that if I have suspicion for my early acromegaly and I have a good surgeon, I would go for it. I would take it out. Not me,
Just a
the good surgeon.
Thank you. That's a very good answer. Actually, I asked other people and I like your opinion. Dr. Ali, just a quick follow-up on acromegaly question. A patient who underwent surgery already, transsphenoidal surgery for acromegaly, what is the best time to monitor the IGF-1 and the growth hormone suppression?
Sure. Provided that the patient was not on long-acting somatostatin analog before the surgery, so naive patient in terms of naive drug-wise, I would check the IGF-1 in 4 months' time. If it is mildly elevated, I would not rush to do anything, and I would recheck it a couple of months later, because we can see patients who, after 3 or 4 months, after the 4 months of surgery, they even normalize the IGF-1. So I'm not in a hurry if the IGF-1 is mildly elevated post-surgery. If obviously the IGF-1 is substantially high, then there is no point waiting longer, and we will have to consider other management options. OGTT, we tend to do it around 3 months after surgery. We can do it earlier if we wish, but I think that the IGF-1 will define our decisions on further management.
Thank you very much. Thank you very much.
Thank you, Dr. Ahmed. The question is 28 years old male with macroprolactinoma, more than 2.7 centimeter status post-transsphenoidal surgery resection. He is in a huge dose of cabergoline, 13 milligram twice weekly, 13 milligram, microgram maybe, microgram. He is refusing a second surgery and radiation therapy. What is your advice? And thank you. This is from Dr. Fatima.
Thank you.
It's a difficult case. This is
It is difficult. So to summarize, a young male who had surgery, which obviously did not.
And left him with 2 centimeter still.
2 point something still there.
2.7,
And the patient is on a really high dose of cabergoline and
yes,
refuses other intervention.
He doesn't want to go back. And no radiation. He is not. Okay.
Well, I think it's a matter of discussing with the patient what his choices will lead him to. What I would do is obviously we would offer, I believe, testosterone replacement. He must be hypogonadal. If he insists that he doesn't wish any other treatment, I would try and reduce the dose of cabergoline. What's the point offering 13 or whatever such a dose? And I would warn my patient that if they don't want any further intervention from what we suggest, then it's his choice. We can't change his destiny if he doesn't want to.
Which one you would recommend actually, to go back to surgery or we go to radiation? Which is the option?
Sure. I think the scans will tell us what is the best option. If the tumor is amenable to repeat surgery, even to do some debulking, I would go for surgery. But if the tumor is not amenable, I would go for a radiation, or sometimes both, a bit of surgery followed by
And then we
radiation. Yeah.
okay. خلاص, clear. Thank you very much. Next question, MRI monitoring after withdrawal of dopamine agonist in microprolactinoma and macroprolactinoma. How often you do MRI just to check the regrowth after stopping the dopamine agonist?
Yeah. Let's take the scenario of a microprolactinoma
Yes.
first of all. We stop the treatment. We are sure, or we believe this will work. What I do is I monitor the prolactin, and once I see the prolactin going up, I don't do an MRI. I put my patient back on dopamine agonist, provided, of course, that the dopamine agonist is needed, and we are not dealing with a postmenopausal lady. If the prolactin just goes up and remains stable, and the patient doesn't wish, or we don't wish to offer any treatment, I would do a baseline scan to have it as a follow-up later. If it is a macroprolactinoma and we stop treatment, this is a bit usually we don't, let's be frank.
Okay.
Usually we don't.
Okay.
Yeah.
Okay. After successful treatment of Cushing, when is the best timing and method to measure cortisol? After surgery, he's talking here. Morning physical. Do we need to do dexamethasone suppression also?
Okay. Let's take the journey of the patient. I'll try to be brief. And I will share what we do here in Birmingham. The patients have transphenodal surgery for their corticotroph tumor. We don't give them hydrocortisone, and we measure cortisol levels every 6 hours. Once we get the magic number of around below 50 nanomoles per liter, we know that the patient is in remission. Of course, we keep in mind if we are dealing with cyclical Cushing's before the surgery, or if the patient was on drugs that reduce the cortisol. But the usual scenario is patient hasn't been on treatment, does not have a cyclical Cushing's. If it is below 50 nanomoles per liter, the cortisol, anytime during this 6-hour interval, we consider the patient that they are in remission. We offer hydrocortisone replacement, initially a little bit of a higher dose, because we want to avoid the steroid withdrawal syndrome. Soon, or as soon as possible, the patient goes on a physiological dose. And then what I personally do is I measure a morning cortisol after omitting the hydrocortisone for 24 hours. I would do this initially after 6 weeks after surgery-ish, and then usually every 6 months, unless the patient presents or mentions manifestations of recurrence of the Cushing's. So every 6 months this, and once I pick up a morning cortisol of hydrocortisone above 150, 200, this is a debate on what is the cutoff, I will do a short synacton test and see if the axis has recovered. Once the axis has recovered, we stop the hydrocortisone, and I monitor my patient for relapse, and we can do either late night salivary cortisol or usually overnight, not low dose dexamethasone suppression test. And between us, our experience has shown that the patient is the first who will pick up the recurrence, and they will come to us and they will mention symptoms and signs. So that's more or less the protocol.
So we'll do stimulation before you stopping the treatment to make sure that
before we stop
if cortisol is low.
Yeah. Obviously, after having a morning cortisol between 150 and 200 nanomoles per liter.
Okay, thank you. For how long should we monitor non-functioning pituitary adenoma, whether micro and macro, with MRI?
Okay, we are talking about non-operated, I guess, or operated?
It looks like non-operated.
Non-operated, because
maybe
micro we wouldn't operate. Well, frankly speaking, I don't think that anyone can give an answer on when to stop imaging follow-up of presumed non-functioning pituitary microadenomas. And this is because we don't have data. We don't have data of follow-up of 10 years, 15 years. And yes, the data we have with a median follow-up of around 3 years or so, they tell us that these are benign entities and we should not worry. However, if I have a patient who is 30 years old and has a micro incidentally found presumed micro-NFPA, and it is, let's say, 6 millimeters, okay, I'm not sure that in 2 years or 3 years, I would say to my patient, no follow-up, goodbye, and we don't need to do anything. Not because that this is not a scenario, a possible scenario, but because we don't have evidence in favor or against that.
So,
Okay, so
unlimited.
when to stop, we don't have data. Of course, if
Okay.
we are dealing with a patient who is 81 years old and we picked up a presumed micro-NFPA, yes, I would do a scan in 1, 2 years, 3 years, sorry, in 3 years, and then I would probably stop or warn my
Okay.
patient for visual deterioration mainly to have to keep an eye on. Macros, presumed macro NFPAs, I would never stop imaging them. They are macros. They became large
Okay.
enough, and we don't know. We have some data which will be published soon, but we
So
don't
in
know.
macro, how long? Every year you will do them? Yearly?
In macroadenomas, I wouldn't do, and those who are far from the optic chiasm, I would do the first scan within a year, not
Right.
6 months. And
Okay.
as I mentioned, we have some data which will hopefully be out soon from the UK NFPA consortium.
Thank you. Good, great. 2 more questions. Is there any rule for sending growth hormone level after surgery right away, immediately? Would it help assessing the response?
Obviously, we are talking about acromegaly. Yeah?
Yes, definitely.
Okay.
Yeah.
Yeah. There are centers which apply this approach. My opinion is that immediately after surgery, the patient is under stress, and a level which may be high, or what we would consider as high of growth hormone, may not mean much. And I don't know how this is going to change our management by sending a day 1, 2, or 3 growth hormone, when in reality we know that we need to wait until we see the final outcome. Having said that, I completely accept the approach of other centers. I don't think there is right or wrong, but I wouldn't. We don't
Immediate.
apply this approach.
Okay. And again, acromegaly. If patient not responding to SSA, somatostatin, what is the frequency of increasing the doses, and when do you add another medication? Also, in case there is the other part, also in case of withdrawing the medication, what are the steps? So, how long you will titrate? The titration and addition of another somatostatin or other medication.
So the dose titration is we offer whatever dose we start with. And obviously, if it is severe acromegaly, it is better to start with biochemically acromegaly. It is better to start with a high dose anyway. But if we want to titrate the dose every 3 injections, after 3 injections, before the 4th one, we would measure the IGF-1 and the growth hormone, but IGF-1 will guide us, and then we titrate accordingly. But again, I repeat, if we have severe biochemical acromegaly, I'm not sure if it is worth titrating dose of a long-acting somatostatin analog, rather than it's better to start with a high dose anyway, provided the patient tolerates it. In terms of when to decide for further treatment, I assume we mainly talk about adding dopamine agonist, cabergoline. If after having the maximum tolerated dose of long-acting somatostatin analog, the IGF-1 has not normalized, and provided that the IGF-1 is not very far from normal, if it is excessively high, I doubt if the patient will respond to the addition of cabergoline. So I would add cabergoline and then reassess and see how things go. Chance of response, I have to admit, in our hands, of adding a long-acting somatostatin analog, adding cabergoline to long-acting somatostatin analog in pure somatotroph adenomas, not the co-secreting. So the chance of good response overall is low, and we had published a collaborative study on this in the European Journal of Endocrinology last year. So
withdrawing of medication when patients reaching improvement, things are stable. When are you going to take it out?
You mean extending the frequency of injections or taking out
No,
completely?
withdrawing the medication, would you take out completely somatostatin analog from this treatment? Reaching cure, for example, or stabilize the growth hormone, IGF-1. When are you going to withdraw your medication, somatostatin analog?
Sure. If my patient has had radiotherapy and we have reached the stage that we feel that radiotherapy has done the job, I would try and reduce the dose of the long-acting somatostatin analog until complete stopping it. That would be my approach. Otherwise, if a patient is on long-acting somatostatin analog without previous radiotherapy, the chances that we will achieve remission of the disease of the acromegaly by stopping the somatostatin analog, they are really low.
Okay. Last question. Would you suggest bilateral adrenalectomy for severe Cushing disease after unsuccessful transsphenoidal surgery? Patient is asymptomatic. Patient symptomatic had diabetes, osteoporosis. There is not expert surgeon available in the region. So you are not treating the pituitary, you go down to the adrenalectomy.
I think bilateral adrenalectomy is still one of the options or in the algorithm for managing Cushing's disease. In severe Cushing's, in which surgery hasn't worked, radiotherapy hasn't worked, it is still an option we could consider, because the patient is under risk because of the exposure to the cortisol excess. Medical treatment is also important. Medical treatment obviously will not lead to remission of the disease. Control maybe, but how long for are we going to have this patient on medical treatment? So for me, bilateral adrenalectomy is still a good option.
What about Nelson? I mean, regrowth of the tumor itself. We exhausted you, Wheeler.
No, I love it. I really like listening to the questions. Thank you for that.
Okay.
So nowadays we are trying to use the term corticotroph tumor progression. Yes, there is a chance that this happens following bilateral adrenalectomy. The question is, by doing bilateral adrenalectomy, are we making the tumor more aggressive, the corticotroph tumor? This is a question which has still not been answered completely. Our opinion, and again, we had a collaborative study in the UK on that. This study showed that the tumors, the corticotroph tumors, which had poor prognosis from the very first beginning, before the adrenalectomy, these were the ones who did badly after the development of Nelson's. So Nelson's is a condition which is not necessarily a quotation mark death sentence. We need to monitor the patient, and if we pick up corticotroph tumor progression, obviously we intervene.
Thank you very much. I do really appreciate your participation and your knowledge and everything. Sharing with our colleagues, we are late already. I will come to conclusion of this session today. Tomorrow we are starting another session, inshallah. So it will start at 3:30 KSA, Saudi Arabia, 4:30 Oman. Please to get your certificate, you just scan the barcode here. So you are confirming getting your certificate of attendance and your certificate also from Dubai Health Authority. I would like to thank all our colleagues, the speakers and the chairs, and our colleagues who are participating, attending this session. And I hope to see you all tomorrow, inshallah, starting sharp around 3:30. We have 3 or 4 sessions tomorrow, inshallah. So all the best, and thank you very much for the full participation. And I thank Choice also for the conducting, and really excellent platform, easy, and it was very useful. Thank you very much all the best, and good night.
Thank you very much for inviting me. Thank you.
Your pleasure. See you soon, inshallah. Thank you.